webinar. As the name suggests, Oncology as on today, the essence from ESMO and WCLC 2022. This webinar is done under the aegis of SOMEX Research and Health Organization. With pleasure, it's a pleasure to welcome Dr. Naresh Somani, who is the program convener, Director Oncology and Head of the Department, Medical Oncology at SCG Cancer Center and Somani Hospital, Jaipur. Once again, a very good evening. Good evening, Dr. Naresh Somani, sir. We give the floor to you for your welcome and introduction and start the proceedings, please. Over to you, sir.
Thanks, Mr. Tarun. Good evening and welcome all friends, those who joined yesterday and those who are joining today. At the very outset, let me thank all the members of the scientific committee, Dr. Vijay Patil, Dr. T.P. Sahu, Dr. Bharat Vashwani, Dr. Vijay Patil, Dr. Vamsi Krishna, and Dr. Vikas Talreja, and all other members who were directly and indirectly involved. And let me share you that based on the various platforms on which this meeting was being displayed yesterday, direct, Facebook, YouTube, and the DocCME channel, which is a new channel, I think the total attendees were more than 150, which is remarkable for the webinars which are currently going on. So that's a remarkable feature, and I would like to congratulate the efforts of the Team Horizon for that. And as you all understand that we recently had the ESMO meeting and the WCLC also. So based on these two important major meetings and few other articles, we tried to articulate the various things out of these meetings and try to design the scientific program for the post WCLC and post ESMO meeting webinar. We are doing the third consecutive years, and we intend physically or non-physically, we will be continuing. So once again, I welcome you all, and let me announce the yesterday's prizes also. So the prize for the best question goes to Dr. Anu Rajpurohit, medical oncologist from Jaipur. I congratulate her personally and on behalf of the team of the webinars. And the other prize, that is for the attending maximum time the webinar, we will be announcing very shortly. So without taking much of your time, let me invite the chairpersons for the today's meeting, my good friends, Dr. Lalit Mohan Sharma, professor and senior medical onco and the hemato-oncologist at the Mahatma Gandhi Medical College and attached group of the hospitals from Jaipur, and Dr. Tarachand Gupta, medical oncologist from Bhagwan Mahavir Cancer Hospital, Jaipur. Over to the chairpersons. Thank you.
Thank you so much in sort of connecting everyone for the meetings. So without wasting much time, we will start with the first session, which will be on pancreatic cancer. To start the first session, may I request Dr. Rajat Channa, who is consultant medical oncologist at Narayana Specialty Hospital, Delhi. And Dr. Rajat, is 7 minutes. Please start your session. Over to you, Dr. Rajat.
Yeah. I am thank you, Somani sir. Thank you, Dr. Lalit. I'm Dr. Rajit, working at Dharamshila Narayana. So I'll be discussing this study, that is PRODIGE 29 Neopan study, which is a phase 3 randomized trial comparing chemotherapy with FOLFIRINOX or gemcitabine in locally advanced pancreatic cancer. So the slide sets are directly taken from ESMO 2020. So this was a French study led by Dr. MP Ducry. So please pardon my pronunciation. So background, pancreatic carcinoma, we know that it is an aggressive malignancy and it is the 4th leading cause of deaths worldwide. And more than 30% of the patients of pancreatic cancer, they are not resectable because of the local extension. And the median OS is dismal, less than 1 year. And we know that in metastatic setting, FOLFIRINOX is better than gemcitabine in terms of OS and PFS, but the standard of care remains gemcitabine for locally advanced pancreatic cancer. So coming to the definition of locally advanced pancreatic adenocarcinoma, it is based on arterial and venous infiltration. In terms of arterial, in pancreatic head or uncinate process, the solid tumor contact is more than 180 degree with the SMA or celiac axis. And pancreatic body or tail, the solid tumor contact is more than 180 degree with the SMA or celiac axis. And venous means that unresectable SMV or portal vein due to tumor involvement or occlusion. So the study design was 1:1 randomization of locally advanced pancreatic cancer with FOLFIRINOX and gemcitabine. FOLFIRINOX was given for 12 cycles every 2 weekly. Gemcitabine was given 6 cycles of 4 weekly interval, and the primary objective was PFS, and secondary objectives were adverse events, overall survival, and objective response rate. Stratification factors were tumor location, investigator site, performance status, and less than and more than 60 years of age. Coming to the population description, the median age was 66 years in both the arms, and most of the patients were of good performance status. Head of the pancreas was present in around 57% in both the arms. Majority of the diagnoses were adenocarcinoma, only 1% were adenosquamous carcinoma. Superior mesenteric artery invasion was present in around 52% in gemcitabine and 44% in FOLFIRINOX arm. Portal vein involvement was in 21% and 28% respectively. Biliary bypass was done in around 28% of the patients in both the arms. Coming to the results, the PFS results favored the FOLFIRINOX, that was 9.7 months as compared to 7.5 months. However, at the end of median follow-up of 41 months, the PFS did not translate into an overall survival benefit. So it was 15.6 months with the gemcitabine and 15.1 with FOLFIRINOX. Tolerance was, as we know, that it was reasonably okay. Grade 1 side effects were present in almost all the patients, and the incidence of grade 3 or more side effects, they were present equally in both the arms. The incidence of grade 3 nausea was 5% in gemcitabine along with vomiting. Incidence of neutropenia was 22% in gemcitabine. So the hematological side effects were more in the gemcitabine arm. In the FOLFIRINOX arm, nausea and vomiting grade 3 were present in 12 and 10% respectively, and neutropenia was present in 12%. The primary results were that coming to the second line treatment, the subsequent treatment before PD, chemotherapy was given in 33% in the gemcitabine arm and 41% in the FOLFIRINOX arm, and radiation was given in 9% in the gem arm and 15% in the FOLFIRINOX arm. Surgery was done in 3% in gemcitabine arm and 4% in FOLFIRINOX arm. After progressive disease, around 48% and 62% patients received chemo in gemcitabine and FOLFIRINOX arm, and radiation was given in 2 and 7% respectively. So I think I have missed one of the last slides. So what this study is trying to show that in LAPC, gemcitabine remains one of the standard of care, and FOLFIRINOX has not resulted in better overall survival. Although the PFS is more and the response is slightly more. So if we are planning for surgery and the patient is fit enough, then FOLFIRINOX, I think, should be used as a standard of care. But due to some reason, if patient is not fit, then gemcitabine is also a very good option, which has demonstrated similar overall survival. So with this, I would like to conclude my presentation, and thank you all for listening.
Respected chairpersons, because we are unfortunately not having the second presentation, so may I request all of you to make some comments and the expert comment based on the first discussion. Dr. Lalit.
So maybe I'll add something more, that gem nab paclitaxel should be a better comparator arm. In this study only gemcitabine was taken, but still it was able to show that gemcitabine had resulted in similar OS. So but the PFS was more in FOLFIRINOX arm. So it has given us the option of using all three combinations in LAPC setting.
Dr. Tarachand, you would like to make comments, expert comments?
For nice, wonderful presentation on product. Has the compare the fall free knocks and that has the good results. I think it can be tried in the LAPC also. Yes, the toxicity is the major concern, but yes, if we are getting overall survival benefit, then it is worthwhile.
Dr. Lalit sir.
So I now invite Dr. Manish Kumar, Consultant Medical Oncologist.
So I think Dr. Tarachan and Dr. Rajat has covered both the things well, and it remains individualized decision. In fact, and
Thank you both the chairpersons. And as we don't have the presentation by Dr. Manish Kumar, so we will be moving to the next session. And this session is being chaired by Professor Dr. Shantanu Sharma, Department of Radiation Oncology at SMS Medical College, as well as our good friend Dr. Abhishek Singh, Senior Consultant, Department of Medical and Hemato-Oncology at the Global Cancer Care, Lucknow. So we request both the chairpersons to start the proceedings. Dr. Shantanu Sharma and Dr. Abhishek Singh, please.
So Dr. Shantanu, sir, you need to unmute, sir. Dr. Shantanu,
Thanks, Dr. Somani. Am I audible?
Yes, sir. Yes, sir.
Yeah. Good evening, Dr. Somani, and thanks for giving me this opportunity. And so may I invite Dr. Taha Sethjiwala. She is a consultant medical oncologist at Mumbai Onco Care Center, Indore.
Hello. Hi. Can someone share my slides, please?
Yes, sir. All yours, sir. Please.
Can you please share my slides?
Okay. You want us to share the slides, sir?
Yes, please.
Okay. My colleague has already started. So,
Hi. So this is IMpower 010. It is an updated data of phase 3 trial of adjuvant atezolizumab versus best supportive care in resectable stage 1B to stage 3A non-small cell lung cancer after adjuvant chemotherapy. Now we are all aware that next slide, please. We are all aware that in case of non-small cell lung cancer, resectable disease, that is 1B to 3A, all of us practice adjuvant chemotherapy, which gives us an absolute improvement of around 4 to 5% at the end of 5 years. Now, the phase 3 study, IMpower 010, where we had seen that there was a DFS benefit, and because of which we have an approval for atezolizumab can be used with PDL1 more than 1% in US and China, and PDL more than 50% in European countries. So they did give an approval of using atezolizumab in a maintenance phase post chemotherapy in adjuvant setting. Now this presentation is giving us the OS data after the end of 45 months. So next slide. Next slide, please. Yeah, so it's an open label phase 3 data where patients with completely resected stage 1B, 3A non-small cell lung cancer, ECOG PS01 or tumor tissue of PDL1 analysis required, were given adjuvant chemotherapy around 1 to 4 cycles. Chemotherapy were platinum based, pemetrexed, gemcitabine, docetaxel or vinorelbine in combination, following which they're divided into 2 arms. One received maintenance atezolizumab 200 mg every 3 weekly for a total of 16 cycles versus best supportive care. And there was no crossover allowed. So the primary endpoint was hierarchical evaluation of investigator assessed DFS in 3 populations, and the secondary endpoints were OS, DFS with PD-L1 more than 50% at 3 years and 5 years. Next slide. Now, if you look at the OS curves at the end of 5 years, with a mean follow-up of around 46 months, we see the curves nicely separating with around at the end of 5 years, we're getting a difference of around 9%. So with patients on best supportive care, there is a 67.5%, and with the patients who received atezolizumab, around 76.8%. The median OS has not yet been reached, but with this we got a hazard ratio of 0.71. So this is with patients in PD-L1 of more than 1%. Next slide. Now, if you look at the OS in other patient subgroup, that is irrespective of the PD-L1 levels, we see that both the curves are not separating, with median OS has not been reached yet. Next slide. If you look at the subgroup analysis, so this is a forest plot, which says that in most of the subgroups, patients on atezo have done kind of better, but because the reference has crossed midline, I would take it with a pinch of salt. But in any case, atezo arm have relatively done better. Next slide. Now, OS by biomarker study. Now, this is seen that irrespective of the EGFR status, patients with a positive PD-L1 level have done better on atezolizumab, especially patients with PD-L1 level of more than 50%. So on the right, we see the curves which are nicely separating. Patients with excluding EGFR, PD-L1 more than 50% have shown at the end of 5 years OS of around 84.8% versus 67.5%. So there's a significant, clinically significant difference with a hazard ratio of 0.42. Next slide. If you look at the safety profile, what safety data we had initially at the end of DFS, when we look at the end of 32 months, now comparing it with at the end of 46 months, there's not much difference. And most of the time, the safety profile is kind of similar. Next slide. So concluding it, in a pre-specified interim analysis of OS from phase 3 IMpower, adjuvant atezolizumab following complete resection and adjuvant chemotherapy suggest a trend towards OS benefit in stage 2, stage 3A, NSCLC, PD-L1 more than 1%. Hazard ratio of 0.71, so there's around 30% reduction in mortality. Patients with PD-L1 more than 50%, there is more benefit, but we still have to wait for the final results. Safety profile, there's not much difference, and investigators concluded that these data continue to support previous findings of currently approved atezolizumab. So patients with a higher PD-L1 level, we can consider adjuvant atezolizumab after completion of adjuvant chemotherapy. I'll say because patients who are EGFR positive, we have a good data of osimertinib. So if patients are EGFR negative with a good PD-L1 level, I think we should consider adjuvant atezolizumab. Thank you.
Thank you, Dr. Taha. So our next speaker is Dr. Aditi Mittal, Consultant Medical Oncologist at SMS Hospital, Jaipur.
Sir,
Dr.
she's
Aditi?
joining in 2 minutes, sir.
Okay, sure. So we shall wait then now.
Yes, we should wait. Any discussions? Dr. Shantu, any question for Dr.
Yeah,
Taha?
any questions? Yeah, any questions? Most welcome.
So for Dr. Taha, Dr. Somani, any questions?
There is a question in the chat box. There is a question in the chat box.
So Dr. Taha, hello, Dr. Taha, can you hear us?
Yes.
So the question is why there's a difference between PD-L1 more than 1 versus between 1 to 49?
Dr. Shah, I was just going through your slides. When it's a PD-L1 between 1 to 49 and more than 1, and there's a separate group of more than 50%. But still there's a difference between 1 to 49 versus more than 1. So I think it remains more or less same, but there is a difference. One is the other side of the this forest curve chart, and the other is not almost at the midline. So what should be the explanation for that?
So I think the number of patients in the PD-L1 level have not been specified. Like 1 to 49 is a very big chunk of patients, sir. And with the increasing PD-L1 level, you get better results. So I think probably that's the reason why we're seeing that difference.
So you want to say that in a group more than 1% includes the more than 50% PD-L1 group also.
Yes, sir.
So, Dr. Somani, I have one question to Dr. Tara. Can I ask him? Am I audible to you?
You are audible, sir.
Am I visible also? No?
At least not to me, sir.
Okay, no issues. So the question is, control arm is best supportive care, if I understood correctly. Is that right? In randomization, one arm received Atijo and the other was control arm was best supportive care.
That means after completing chemotherapy, they've not received any further treatment, sir.
Okay, so everyone received chemotherapy.
Everyone has received chemotherapy, sir. The randomization occurred after receiving chemotherapy. So Atizo gives a benefit over chemotherapy, sir.
Atijo plus chemo is better than chemo alone. This is what the final conclusion is.
Yes, sir. Like patients if they receive maintenance Atizo after completing chemotherapy, will give better results compared to patients who don't receive any maintenance treatment.
Right. Okay, got it. So I think we still need some markers where we can predict the good response with such drugs, in fact. But this is good, and we all know about the PD-L1 that the higher expression is probably better responsive to the immuno-oncology drugs.
Yes, sir. That's what even the data says, sir. More than 50% results are better.
Right. Thank you. Thank you so much.
Thank you, sir.
So, Dr. Shantanu, sir, we have Dr. Aditi with us now. If we can invite her for the next talk, please. Dr. Shantanu?
Dr. Abhishek is here also, sir.
Yeah, Dr. Abhishek, if you can invite Dr. Aditi for the talk, please.
Have you upgraded Dr. Shantanu?
Yeah, he's there.
Our next speaker is Dr. Aditi Mittal. She is a consultant medical oncologist at SMS Hospital, Jaipur. Is she here, Dr. Aditi? Dr. Aditi?
Aditi, please unmute yourself.
Yes, I am here. Yeah.
Yes,
sir, I'm here. Can the organizers please upload the slides, or I'll do?
Ma'am, you can.
Kindly do. Okay, I'll try. Just a second. Ma'am, can we share your slides? Yeah, it's opening in PDF format. Can you open in PPT? I'll share your slides. Yeah, please. So, okay. Yeah, can you come to the first slide only? Yeah, thank you so much. So, first of all, I would like to thank all the organizers, especially Dr. Somani, sir. So, it was given to me at the last minute, so not much to prepare, but it's a great trial, I would say. So, this trial was done in a very, I would say, a very important subset of the population. So the trial was ipilimumab plus nivolumab and chemoradiotherapy, which is the standard of care, followed by surgery in patients with resectable and borderline resectable lung cancer. It was named as INCREASE study. Please change the slide. Yeah. So of course, next. So the rationale was a segment of stage 3 patients with a high T stage and a low N stage, such as superior sulcus tumors, are typically borderline resectable, and they may become resectable after induction with chemoradiotherapy. So but it was observed that even after giving chemoradiotherapy, the PCR, the pathological complete response in the specimens that we resected was very less. So to increase that PCR, it was hypothesized to add immunotherapy, CTLA-4 inhibitors and PD-L1 inhibitors. So radiotherapy using a platinum doublet and a concurrent conventional radiotherapy to 60 grays associated with a pathological complete response rates of almost 30%. So chemotherapy combined, don't change, please. Chemotherapy combined with immunotherapy in resectable NSCLC improves PCR rates. That has been hypothesized, and that has been proved in some trials also. So it was postulated that preoperative CRT with concurrent dual checkpoint inhibitors, a CTLA-4 and a PD-1 inhibitors, could enhance the pathological and immunological response rates through activation of antigen-presenting cells and effector T cells. Next slide. So what was the trial design? The trial design was quite a bit complicated, I would say. So inclusion criteria, of course, a borderline stage 2, B2, 3 CA lung patients eligible for post-induction resection, means they has to be a bit fit patients rather than very old and frail, PS 0 to 1. And there was the N was calculated based on some, it was calculated as 26 to 29. So there were 26 evaluable patients in them. Very small number, but yes, it was statistically okay. So what they did, they gave the chemoradiotherapy as the standard thing, plus they added the ipi-nivo, 1 dose at the starting of the chemoradiotherapy, and also 1 dose of nivolumab after day 21 days of chemoradiotherapy. So of course the staging was done as it is done for all our patients with a PET scan, with the MRI brain, and of course the mediastinoscopy if it is needed for complete staging of the patient. And within 6 weeks of completion of the chemoradiotherapy, patient was resected. Patient underwent resection, and then the PCR was measured, of course, in the resection. And PCR was, of course, a complete absence of tumor, and there was also measured major pathological response, in which less than 10% of the specimen showed the tumor. And then, of course, there was follow-up. The primary endpoint was PCR, secondary were DFS and the OS. Next slide. It was a phase 2 trial. So if we see this, so we have a median age of course, the elderly, 64 was the median age, almost similar male and female. Smokers were more. And then they were all PD-L1 expression was it was mixed PD-L1 expression, and this is the data. Okay, next. So yes, so this talks about the adverse effects in these patients, because in chemoradiotherapy also we observe much adverse effects in these subset of population, but with addition of immunotherapy, yes, we have the adverse effects bit increases, not much, and it was quite manageable. So any adverse effects was almost every person had the adverse effect, but yes, the grade 5 was 0 among this, and any patient leading to IU discontinuation was only 7% in 7% of the patient. So the most common adverse effects for dermatitis, and then there were thyroid disorders, pneumonitis that we already know with the immunotherapy. Next slide. So PCR. So we can see the patient who underwent resection, the PCR was present in 63% of the cases. Yes, it was, the number was small. It was 15 patients out of 24 patients. But yes, still it was 63% of the patients who achieved PCR, which is a big deal, because chemoradiotherapy has the data of only 30%. That is almost doubling of the PCR. MPR, if we would say, that is major pathological response, which was also present in a 79% of the patients. So we can see the tumor regression was almost very high. As in this plot, we can see almost 100% was many patients, and very few patients had very less response. So of course, these patients, this subset maybe having different biology. Of course, that has to be more done and more investigated in further trials. But yes, the response rates were quite awesome. Next slide. So what you would say, the PCR was good, but the radiological response was not very good. So if we would see The stable disease was present in 81% of the patient, if we can see in this thing. And they were resected also. But for the patients who had stable disease, they had PCR in 87% of the patients. So radiological response is not the ideal thing to actually judge how patient has responded. That inference can be made from this. So next slide, please. So this is just a case that they have told that there was a 43-year-old man. Don't change the slide, please. Please put on the slide. Yes. So we can say there was a radiological stable disease was there, but metabolically the patient had a complete response, and of course the pathological patient had a PCR. So of course CT, we all know PET CT is a better modality, and we should always assess with a PET CT. And we should notice that in this, the PET CT was done within a month of the CRT. It was not done after 3 months, but within the 1 month of the CRT, and then they did the resection after 6 weeks. Next slide, please. So the hypothesis is that when we give the immunotherapy before the resection, it induces memory T cells. It increases the CD8 plus T cells, which actually decreases the recurrence of the disease. There is memory T cells which eats up, of course, the cancer cells, and the body is more primed to kill cancer cells rather than only with chemoradiotherapy. So that's why immunotherapy has to be given in neoadjuvant setting rather than adjuvant setting, in which there is more antigen load, more T cells would be activated, and then they will become the memory T cells, and then thus they would lead to decrease of recurrence of the disease. So you can see in the last so activated CD8 increase versus control was there. So we can see there was a quite increase in the CD8 plus cells. Whether it translates into DFS or not, that is of course still a debate to be investigated. But yes, this is the hypothesis that is being given for usage of immunotherapy in a neoadjuvant setting. Next slide. So we can conclude this is the phase 2 trial still. In a selected population comprising borderline operable high T and low end stage tumors, ipi-nivo, single dose ipi-nivo plus 1 nivo with concurrent chemoradiotherapy resulted in high pathological response rates of almost 63% PCR and MPR of 79% in the operated patients. Toxicity rates were almost similar, were acceptable, and no patient failed to undergo surgery due to adverse effects. The regimen of the chemo-radioimmunotherapy may be associated with increased CD8 plus T cell proliferation in the tumor draining lymph nodes and in blood, and may result, we don't know yet, but still may result in a greater DFS that we can have. Thank you so much.
Thank you, Dr. Aditi, for your nice presentation. And we sincerely hope that the hypothesis we have proposed may come true and more people get benefited from that. So next speaker is Dr. Kripa Bajaj, Consultant Medical Oncologist at Indo-American Hospital and Research Institute, Hyderabad. Dr. Kripa?
Yeah. Can I share my screen?
Yeah, sure.
So the study which I'm going to discuss is a negative study. It's so important for us to discuss the negative trials as well, apart from the positive trials. So the hypothesis, the concept was very different, like apart from the routine oncological trials where we know where we are targeting, where we are heading in the study. So it's a Canopy A trial. It's a phase 3 study of canakinumab as adjuvant therapy in patients with completely resected non-small cell lung cancer. So where does the concept of using canakinumab? For the audience like who are listening to this, canakinumab is not an oncological immunotherapy drug or something. It's anti-interleukin 1 beta monoclonal antibody. So from where the concept of using canakinumab in lung cancer came? It's from the CANTO study. CANTO study is a very famous study which was done in a patient who got a myocardial infarction. It's a cardiovascular disease. Those patients have a raised CRP. We all knew in internal medicine, raised inflammation in the body predisposes to atherosclerotic disease. So atherosclerotic disease, like we introduced the anti-inflammatory marker, the reinfarction rates and all got studied. It's not the small cell lung, non-small cell lung cancer incidence which got studied, but it's the reinfarction rates, other CVA events got studied. But accidentally, when they did the retrospective analysis, they found that whoever received the canakinumab, the 3 doses they gave, 3 monthly 3 doses they have given, not only just there is a decrease in incidence of cardiovascular events, but also there is a decrease in non-small cell lung cancer incidence and mortality as well. So from there, the concept got picked that decreased inflammation in the body can predispose us to the can decrease the lung cancer incidence as well, because all of us know atherosclerotic disease, one predisposition is smoking. So smoking not only lead to cardiovascular disease but also to the lung cancer. So if we introduce anti-inflammatory, can it like decrease the incidence of lung cancer was the concept. So there they conceptualized it. The role of inflammation in lung cancer, it's already studied and well established. So will this inflammation getting targeted will harness therapeutically is a question. So that's there the idea has come. There are different doses used there also, that is a 50, 150 as well as 300 in Canto study. So how this study has happened? So the study included the stages, stage 2A to 3B, both all got resected, but whoever are node negative, they didn't receive any chemoradiotherapy, but who are node positive and all like criteria of like fitting into the chemotherapy, giving the adjuvant chemotherapy, they received adjuvant chemotherapy radiation as well. Following that, they received a canakinumab 200 mg every three weekly. For likewise, they received a 1 year, almost 18 cycles they received. So, and later the radiologically sequential, they got evaluated and survival got a follow-up done for this kind of patients. The primary endpoint of the study is a DFS. Key secondary endpoint is OS, only if DFS is statistically significant. The patient group, like in both groups, both canakinumab group as well as placebo group, the age, sex, ECOG status very well matched. The predominant population, histology is adenocarcinoma. It's non-squamous cell carcinoma, and squamous predisposes to only 25%. So it's a more of adenocarcinoma group which got included here. And the stage which got included as a 2B and 3A is the predominant group. It's almost consists 80% is a 2B and 3A group. And when it comes to smoking history and chemotherapy, there are former smoker, current smoker constitutes almost 75%. Only the non-smokers constitutes only 25%. Only a quarter constitutes that. And 90% of the patients, so more than 90% of patients received chemotherapy in this study. So almost all are like predominantly 2B and like 2A, whoever are eligible to take a chemotherapy, who request chemotherapy. And PD-L1 negativity are, less than 1 are missing is almost constitute 80% again. And CRP level low as well as missing, it constitutes 50%. Half is this category and half is other category. The patient, if you see, they got randomized and they got like complete treatment, and they got serially got evaluated for the follow-up with the different radiological investigation, different time points. If you see the radiological investigation time points, first year, they got radiological evaluation done every 12 weekly. In the second year, third year, they got done every 26 weekly, and later annually in fourth year and fifth year. So if you see this is a negative study, absolutely 2 curves are bang on. There is a minimal benefit is which is statistically insignificant. The DFS was not at all significantly improved with the canakinumab versus placebo. 35 months versus 29.7 months, the hazard ratio is 0.94. And the p-value is 0.25. Clearly, there is no significant DFS benefit. If you see the curves and all, there is slight predisposition, there is slight erring towards canakinumab, but that's not statistically significant. The subgroup analysis also did not show any meaningful differences between 2 arms for DFS. You see the lung cancer specific survival, again, absolutely no difference. 2 curves are bang on. The hazard ratio is 0.90. And OS was not formally tested, as I already mentioned, because DFS was not statistically significant. They didn't test OS again. Only 100 events were reported, 44 in canakinumab group and 56 in placebo group. Lung cancer specific survival is nothing but defined as the time from date of randomization to date of death due to lung cancer was similar between both arms, as I mentioned. No DFS, no LCSS benefit. OS was not formally tested, but tested, there is no difference at all. Or if you see the serious adverse events, the total fatal adverse events are similar between the 2 arms. Canakinumab did not predispose to any significant adverse events. On treatment deaths were numerically lower in canakinumab arm compared with the placebo arm. So What is the most common adverse event one has seen? It's infections were the most common adverse events, and it took us everyone took a special interest that it predisposed to infection. Only 2 adverse events were reported in more than 10% of the patients and were less common in Kenacumab group compared with the placebo arm. It's a cough, arthralgia, all these things. But the significant event which caught the attention, which caught the statistical significance is the infections. So what's the conclusion? By introducing this drug with the concept of decrease in the inflammation, the primary endpoint of DFS was not met with hazard ratio 0.94. Even the subgroup analysis was done based on demographics, baseline disease characteristics, and biomarkers of interest. Again, did not show any meaningful differences between the 2 arms for DFS. No new safety concerns. And again, exploratory biomarker data from Canopy A will continue to be analyzed, including tumor molecular profiling and longitudinal analysis of circulating inflammatory markers. And to reveal the exploratory biomarker data, which is very interesting, which is a bedside medicine, I would say. Can this really convert into the bedside application is a question. But as per this data, the Canopy A, which was like shown here, there is not much benefit. Even the subgroup analysis clearly showed there is no benefit of adding interleukin 1B inhibitor. So the collective data gained through the Canopy program will provide insights on the role of interleukin 1B inhibitor. So this is a study, very interesting study with no significance and failed to show any benefit. I thank organizer once again for giving this opportunity. Happy to take any questions.
Thank you, Dr. Kripa. Very nice presentation. So, are there any questions? If they are not, then may I have the most interesting part of this today's meeting, the panel discussion. So, may I request Dr. Ullas Batra, Consultant Medical Oncologist at RGCI Delhi, to moderate the session. Dr. Ullas, are you here?
I'm absolutely here.
Yeah.
Sir. No.
Yeah. So may I invite the esteemed panelists, Dr. Lalit Mohan Sharma, Dr. Tarachand Gupta, Dr. Aditi Mittal, and Dr. Ankur Punia. So Dr. Ullas, all yours.
Okay. How much time do we have? 20 minutes?
Maybe. Dr. Somani, what do you say?
Yes, sir, 20 minutes, sir.
Okay.
Okay, fantastic. Okay. Can I please request my panelists to put on Dr. Tarachand? I can see very well. Ankur, can you? Yeah, Ankur, I can see now. Dr. Lalit, sir, can you put on the other video? And Aditi, Dr. Aditi, I can see them all. Great. So we are here to discuss about the panel discussion about the abstracts which are presented at WCLC and ESMO. And the first abstract over here is ipilimumab plus nivolumab and chemoradiotherapy followed by surgery in patients with resectable and borderline resectable lung cancer, the INCREASE trial. And, you know, my first reaction when I actually saw this abstract, the name of this is, you know, the first thing which comes to mind about INCREASE is the request letter to the boss for increase in salary. I mean, that's the only letter that we will write for increase. That nothing else we will write. My boss's reaction on reading this reaction is basically, no worries, you will get your salary increase when you will get more experience. So maybe that basically means that you will have less hair on your head. And now I understand why Dr. Somani has less hair on his head. So Dr. Somani, can I also see you on the screen over here with less hair? So maybe that is why the money is directly proportional to the less amount of, or inversely proportional to that, sir. And this is what my boss's reaction finally is when I go for a salary hike, and I'm sure everybody, Dr. Aditi is also smiling very nicely onto that. This is exactly what we all feel when we go to our bosses to increase the salary. But let's come down to what we actually are here to discuss about. And so what do you think? Ankur, I'll start with you first. What do you think was the reason behind naming the trial as INCREASE? You know, look at this. I का ipilimumab, N का nivolumab, chemoradiotherapy, R, E पता नहीं कहाँ से वो therapy में से E ले आए, S ले आए, मतलब surgery का E ले आए. This E sounds very, you know, this thing. So what do you think was the reason behind naming the trial as an INCREASE trial?
I think, sir, maybe just showing the increase in the PET CR or CR rates.
Increase in the pathological CR. We are trying to convert a lung cancer into a breast cancer or a colorectal cancer now. Dr. Tarachand?
Ankur is saying rightly that now the more and more focus of the pharmas, you can say that company is to increase the PET-CR. They have got the surrogate marker of overall survival, that is the PET-CR. So what will we lose or what will we get after giving so many medicines? Now doublet, single immunotherapy, doublet immunotherapy, and then adding something also, and then how much PET-CR will give us and will take us from us. Will take
maybe increase in PCR. Dr. Aditi, madam, what about you? What do you think increase stands for? Definitely not the salary for all of us. So what else does it stand for?
So it looks like the number of drugs that doctor has to handle and the patient has to handle the adverse effects actually.
Immunotherapy, matlab Nivo, EP plus chemo plus radiotherapy, I mean.
Everything which is available on the plate, followed by surgery.
Followed by surgery. So I mean, kuch reh gaya to bata do bhaiya usme. Maybe the only thing which was remaining was the Baba Ramdev therapy or something of that sort, So that was which was basically causing a lot of headache. I mean, I didn't understand the first time I came and I said, okay, nivolumab, ipilimumab, you have radiotherapy concurrent, you have a surgery. It's a difficult trial actually. But let's critically analyze the trial and its rationale. So let me start with Dr. Lalit Mohan. Dr. Lalit, sir, are you a believer of neoadjuvant chemotherapy in lung cancer? I mean, we all keep on giving neoadjuvant chemotherapy, but to me, most of the times, if it is resectable, it's resectable. Otherwise, when that surgeon doesn't want to leave or let go of a patient, they say, "Tum like 2-3 cycle chemo de do, fir dekhte hain kya karoge." And that is how the people come to us. So, what is your take, sir, on neoadjuvant chemotherapy in lung cancer?
I think routinely in practice with the available cytotoxic chemotherapy, we do not subject them for neoadjuvant. But of course, the neoadjuvant sounds very good in fact. And like in breast also, we are seeing in high risk triple negative, which are sort of more of immunogenic drugs responsive treatment. And same thing applies here. So to me, this particular study looks very rewarding in the form that we may be having more PET-CR and more conversion of the PET-CR translating into the OS and DFS.
So you feel that the intent of neoadjuvant chemotherapy is to increase the PET-CR and the MPR. That is what you actually feel and you are excited on. But sir, how many times do you give neoadjuvant chemoimmunotherapy in lung cancer right now?
Honestly, never. I have never given.
Honestly. How many times only neoadjuvant chemotherapy, sir? Sir has got a phone. Okay.
No chemotherapy. In fact, neoadjuvant setting, no chemotherapy as well.
No chemotherapy as such.
Commonly, we see in advanced stage. So at least I see not less than stage 3A or B. In fact.
Okay, Dr. Aditi, how many times do you give neoadjuvant chemo or a chemoimmuno in lung cancer?
Sir, definitely not chemoimmunotherapy. But sometimes when the patient is not very convinced of the surgical resection, rather than the doctor, the patient wants some time to think and to assess the pros and cons of the surgery sometime. So yes, by the time, yes, we do give.
Dr. Tarachand, your take?
Sir, I have not given a neoadjuvant immunotherapy in a single patient till now. Okay. And even I did not find that patient is fit for surgery or very fit for surgery later on, and I gave the neoadjuvant. Usually patients come for the neoadjuvant chemotherapy followed by chemoradiation to us in the lung cancer.
But typically right now, I think what we are hearing from everyone is that, when in doubt, when the patient is in doubt and the surgeon is in doubt, then you give neoadjuvant chemotherapy. But Dr. Somani seems to have a different take. He says, and with the neoadjuvant immunotherapy coming up, we should we should get more into this. So let's come to neoadjuvant chemoimmuno. I don't think anybody has great experience. We hardly have some 5-6 patient experience also as a part of clinical trial. So let's start about this trial right now. I'll go to Ankur first. Ankur, your comments about the trial design. What do you think is the trial design? And okay, requesting Dr. Somani is asking, requesting everyone to ask questions to win prize. So the moderator also asks, okay, fine. Maybe I'm the one who will ask the maximum questions, so I'll get the prize. So Ankur, what is your comments about the trial design?
So basically, I think, sir, what they wanted to do doing this trial was to see the, combining immunotherapy basically with modulation with radiotherapy, because they planned for chemoradiotherapy as a pre-op treatment, but they combined immuno because now the concept is coming that if you combine with radiotherapy and immune cells, the proliferation effect is more. So maybe that was the rationale behind combining immunotherapy, but I don't know with CRT, which is not the standard of care, like immuno plus CRT, then surgery. So
Okay.
it's a
Dr.
little bit
Aditi?
complicated, or not not a trial which can go directly into practice.
Fair enough. Dr. Aditi?
So too many modalities to be used at the same time, of course. The patient has to be very fit. Sometimes we generally don't get in the clinic so fit patients of lung who can tolerate each and everything of it. Plus,
Okay.
a surgeon also has to be very confident enough of dealing with all these therapy side effects during the surgery.
Okay.
That
Dr.
the patient
Tarachan?
is.
Sir, same with Aditi, and usually so many therapies in a neoadjuvant setting. It will be I don't prefer using.
Okay. So there were two things that came to my mind. One was only 26 evaluable patients which were basically seen on this. So that was something which is very low. I think let's not criticize the RTCT a bit too much. This was basically used in patients, if you see over here, on invasion of thoracic wall, vertebra, mediastinum or diaphragm. So this was basically used in patients with pancreas tumor. So that was where you actually give chemo RT and then surgery later on. So I heard the discussion which was there in ESMO by the presenter. He said they were a referral center for only pancreas tumor. So most of the patient, and I'll come to you in the next one, these were the ones who basically had a pancreas and then they were given induction chemo, radio, along with the doublet immune, and that is how they underwent surgery after that. Then how is this trial different from the other trials? The one very important point again over here, these are the all new adjuvant trial, and what Dr. Somani was and Dr. Lalit Mohan Sharma was saying, most of this trial like Checkmate 816, Empower 030, Keynote 671 and AGIAN study had resectable patient. Now this was a patient which tried to convert a borderline resectable to resectable. So in breast cancer, we have a locally advanced inoperable breast cancer to operable breast cancer. You have a locally LOBC, that is locally operable to a breast conservation. So this was probably a trial where there was a borderline inoperable lung cancer, which then got converted to, they were trying to get it converted over there to surgery. That was the difference between this trial and the other trials actually. The primary endpoint was a major pathological response. So I'll come to Dr. Lalit Mohan. Sir, does your pathologist report it as major pathological response, or they'll just write PCR or not basically? And what do you think is the ideal endpoint for immunotherapy in the adjuvant neoadjuvants? Will you look for OS, EFSJS, PCR, MPR? Do you think? Sir? I think sir is okay. I'll come to Dr. Ankur.
So basically, they took a major pathological response because of such a small number of patients. Routinely, personally in my practice, we don't see that much of lung cancer patients which get operated, because very few patients come to us in such an early setting. So we usually, or I have seen only other PCR, not a major pathological response, which is kind of a new thing in the lung. I have not seen usually.
Yeah.
As for the endpoint, ideally the gold standard is, ultimately OS, but I think rather than PCR, EFS is a better endpoint. But again, that needs a little bit larger number of patients for such a small trial.
So if you look, Dr. Ankur, and all the trials, primary endpoint over here is either MPR, RFS, OS, and MPR. So, the word is moving towards MPR. Even the Perjeta study, the breast cancer study, was approved on the basis of increased pathological CR. So pathological CR is something which is always a issue. What I'll try to show you over here is MPR versus PCR in lung cancer. Why did MPR come into lung cancer? Was that PCR basically was seen infrequently in lung cancer, less than 10%. So major pathological response was basically proposed as surrogate marker, which was defined as 10% residual viable tumor. And then they found out that this was also predictive of long-term OS after neoadjuvant chemotherapy. So in lung cancer, you don't actually look at the PCR, you basically look at the major pathological response. And I think all our pathologists should start reporting this also very important. Now, does this PCR MMR in lung correlate with EFS? Yes, it does. This was the trial which was the nivolumab plus chemotherapy in Checkmate 816, which basically showed that it was very important. Anything to do with this, Dr. Aditi, patient disposition and characteristics, anything of interest that you would like to point it out and from this? So again, I'll ask your comments. Autoimmune disease was there in 4 by 26. I mean, 12.5% getting autoimmune disease, and Nivo and ipilimumab is in a clinical trial setting. is fantastic. I mean, their ethics committee must be very commended to give so much of autoimmune disease. And the second point which came to my mind was, again, this T3, T4 was basically higher over there. And the radiation dose which was given was 50 gray. So this is basically the, this is not the definitive CTRT dose that we give 66 grays or 62 grays. It is the pre-op CTRT dose that has actually been given, which was there in the Pancreatic tumor. So this was what was the important thing. Very important again over here is the induction therapy was started 26 and 24 people were operated. So a good number of people did get operated. So that's a very interesting point from our point of view, that fine, it's not that people are not getting operated actually.
Yes, sir, one more thing, can I say, sir?
Yeah, please.
Almost 60% of patients had a PDL1 more than 50% in the study.
So we will come to PDL1 also. We will come to that, okay? This is TRAEs, which was there. 67% of patients had a grade 3 or grade 4 treatment adverse events. Now, which is also very, very high actually. So any comments, Dr. Lalit or Dr. Tarachand can take it? Dr. Lalit, if you are there, sir. Or maybe Dr. Tarachand can take it then.
So grade 3-4 toxicities which were observed around 67% and the number 18%. I think these were all immune-related side effects or chemotherapy-related side effects, because immune-related side effects are not so observed in any trial other than also not in neoadjuvant setting.
Absolutely right. That is why I put it was not the immune-related side effects, it was actually the hematological toxicity which was there with the CTRT1. So the IO toxicity which I have put across over here are by and large similar to what we normally see. But it was the hematological toxicity which was basically seen, and you're absolutely right. Now, this is what the PCR report with Checkmate 816 is 24 and 37%, which was the difference which was there. This is the PCR rate 63% versus 79% in patients who had received induction. So this was very, very nice. The identified the 3 people who did not get it. PDL1 had no importance, and EGFR and all also there was a discrepancy. So are you impressed with these results, Dr. Ankur and Dr. Aditi after that?
Yes, sir, definitely. It's a very good result for in this setting. It's a pretty good seeing in the lung cancer setting such kind of response rates with just pre-op CRT.
Okay, Dr. Aditi.
Yes, sir. Definitely, the MPR has increased a lot. If we see from the compare with the previous studies, whether it translates into OS and PFS, that is of course a question to be asked.
We don't know. Okay, so this has basically got a 63% PCR, 79% MPR, toxicity rates were acceptable. No patient failed to undergo surgery. Do we agree? Okay, just score the trial on a scale of 0 to 10, and then we move on to the next one. Rate the trial 0 to 10. I mean, how good do you think the results are? Dr. Aditi, I'll chat with you.
6 maybe, sir.
6
I don't
maybe.
know.
Fantastic. Yeah. Dr. Ankur.
8, sir.
8. Dr. Tarachand.
Sir, I will stick to the 5. That is not in the favor and not the against, as the number of the patients are low, and even we can keep the finances apart, but still the finances are of matter, and that is too great. And the PATH CR which has been achieved, it is translating into the OS or not, it is a matter of the time also.
I also think, I mean, although I am not from Rajasthan, which is the seat of the high political discussions nowadays, Delhi is always the seat of high political high command status which comes over there. But I also think, although the PCR rates are higher, but just 26 patients, is not a randomized control trial, good amount of people with toxicity. Basically, if your surgeon really feels, and this was not compared against only nivolumab, so now why not nivolumab plus CTRT? So it's a good hypothesis generating a trial, not something which I will take it to my practice on tomorrow or something. But yes, it's making sure that yes, neoadjuvant chemoimmunotherapy also has a role in lung cancer, and we need to define this basically further. So the next trial,
Ullas,
yes, doctor. Yes, doctor.
My camera is not fully working. In fact, this looks a good trial, at least in the form of, like you say, hypothesis generating or thought provoking. That the neoadjuvant immunotherapy works, and the PET-CR also translates into maybe in long-term success also. So this is probably first time we are listening to almost 70%, 80% patients showing response. So this looks a good beginning. In fact, may not be the true result with the larger pool, but at least very good insight, in fact, where we feel that this could be a way to treat them.
True that, sir. True that, sir.
Sorry to interrupt. There is a question in the chat box regarding the mutation.
So no, so if you have a mutation, this won't work, sir. I mean, so I think we have come to that. If it is EGF or ALK positive, it will not really work, sir. So the next one is Empower 010, which basically says it was an interim analysis of the overall survival, which was post-surgery. This was a study. After patient has received 1 to 4 cycles of chemotherapy, you crossed over to atezo versus none. A hierarchical study design, DFS in PDL1 TC from stage more than 1 first, then all randomized stage 2 to 3A, and then DFS in ITT population. And if this is positive, then OS in ITT. So we are right now, this is the interim analysis of the overall survival. Complicated study design, actually. I will not lead to the DFS versus the OS right now. This was the DFS results. So basically, based on this result, atezolizumab was approved as the adjuvant therapy in people more than PDL1 1%. And the major and it was not found to be effective in less than 1%. Again, if you see, this is the approval status, and the majority of the benefit was basically, if you see here, was obtained with PDL1 more than 50%. So did you change your practice based on these results? Did you start giving adjuvant atezolizumab, or we are still saying that we don't have many patients? Let's say, Dr. Aditi, if you have a patient tomorrow morning, PDL1 5%, will you give this adjuvant atezolizumab?
So of course, so that's a really difficult question. I will consider, I will tell you the pros and cons.
I am thinking about the prize, which Azharuddin has won. I also may get a prize for the next one. So you are not sure, Dr. Aditi.
Yeah, still I would, I think I'd need more data to advise my patient to go for atezolizumab.
What data do you need, Dr. Aditi?
OS
data? Okay, we will show you OS data also. We will show you OS data. Dr. Tarachand?
Sir, I think we should wait for the OS data first thing. And the data in support of atezolizumab is in the PDL1 positive patients. And again, this has not been tested for the EGFR also, where we have the ADORA trial also. So there are some
in ADORA trial, you will not. In ADORA trial, you will not give. If you somebody is EGFR mutant, you will not give atezolizumab. You may or may not give adjuvant osimertinib. That we will keep on discussing. That's a separate issue altogether.
Yes.
So this was Dr. Aditi. The overall survival of PDL1 more than 32%. At 32.8 follow-up, you had a HR of 0.77. At 46 follow-up, you have 82.1 versus 78.9. So at least at 3 years, these many people are living. So HR is 0.71. Happy or not? I knew somebody will say OS. Are you convinced now? You need some more data.
I would give the option. I would give.
Okay. There is an option of giving adjuvant immunotherapy. I think the only issue is, should be given to all the people, or only with a stage 3 disease, or with a higher PDL.
1 minute, sir. What is happening in the last 5? Those curves are mating each other.
No, not really. Actually, if you can see over here,
around you see after the 60 months. Then why these are the paragraphs are merging? Why these graphs are merging?
I'll show you where the curves actually match. So that is why I was thinking. So this was the chemotherapy trial in IALT trial, where the curves actually after 4.6 years to 7.5. This is where you actually say the curves are matching. After 4 to 7 years, the HR of dying was higher in a patient who had received chemotherapy. So this is where I would suggest that the curves are matching. But in the other thing, I think the curves are actually separating, and there's a good, see, if you look also over here, you had a HR of 0.77 and now you have a HR of 0.71. So probably immunotherapy, as we all know, the tail of the tail is actually working over there. Let's complicate it further, as you said, and this is the most interesting thing. It was PDL more than 1%, but the majority of the benefit in PDL1 was derived by PDL more than 50%. If you look at TC1 to 49%, your HR is actually 0.95. So that is what I showed Dr. Aditi. That if you have a NSCLC resected And if you have a PDL1 5%, I will not rather actually give adjuvant immunotherapy because the majority of the benefit is being derived by more than 50%.
More than 50%.
Since we are just running short of time, I'll complicate it even further. So just see this graph. We are all concerned. This is, you know, this is what actually tells that yes, more than 50% you will have this thing. Let's even complicate further. There was another trial basically of the pembrolizumab in the adjuvant setting. And in this setting, absolutely different results. People of PDL1 more than 50% did not derive benefit. People of PDL1 less than 1% derived benefit. So whether it is because of the statistical design or just by chance, we don't know. So, you know, this is exactly my feeling right now. You know, I actually want to bang my head, but this is just the evidence. This was a summary slide by the discussant. I think there's enough evidence to use immunotherapy in stage 2, stage 3. I will use in stage 3. I think subgroup analysis is subgroup analysis. Let's not torture the data too much. Minimal residual disease may be a key to build de-escalation trials, and that is what we think it will come out to be. The final reaction basically was the Canicumab study, and my first reaction on that was APCON. I mean, Atizo malum tha, Pembro malum tha, Nivo malum tha, Durvalumab tha, abhi Canicumab kaun aa gaya hai. So this was Canicumab study, which Kripa very nicely presented, and this had shown something. This is a trial design. So after chemotherapy, you take Canicumab and placebo, and this was the DFS OS. So just a one-line answer, Dr. Tarachand, yes or no?
Sorry, sir.
Sir, yes or no? Canicumab, yes or no?
No, sir.
No. Dr. Aditi?
No, sir.
Ankur has already gone. Ankur doesn't want to even listen to Ankur is there. Okay, yes, Ankur, yes or no?
No, sir, not at all, sir.
Okay, Dr. Lalit Mohan also said no. Don't bother me over there. Okay. So I think my conclusion is that let's pack up and leave. You know, I mean, Canicumab is not really a very good study right now. So just to conclude, immunotherapy is making rapid strides in the adjuvant and neoadjuvant settings. The secondary endpoint subgroup analysis are hypothesis generating, not practice generating. OS data will confirm the utility of immunotherapy in the adjuvant and the neoadjuvant setting. Are we going to cure lung cancer? That is where I'm going to come to, and hopefully we are going to cure lung cancer. So with this, thank you. It was a difficult 25 minutes, you know, something which you don't see very often. But as usual, it was fun discussing with all of you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, panelists, and thank you, Dr. Ullas. It's always a pleasure listening to you. So now we move forward towards the pharma session. So may I invite Dr. Ajay Yadav for the first session with the AstraZeneca trial. Dr. Ajay.
Yeah. Hi, good evening, everyone. My slides, please. Am I audible?
Yes, sir.
Should I start?
Yes, sir, you can start, sir.
So good evening, everyone. Today we will discuss about updated results of Dura trial. Osimertinib has been shown its efficacy in metastatic lung cancer with EGFR mutated patients, but does it also work in adjuvant setting? To answer this question, Dura trial was designed. Next slide, please. So this was the trial design. Patients who were rejected and having margins negative, having stage 1B, 2 or 3A NSCLC with the EGFR mutation positive, either exon 19 deletion or L858R. Patients who were having performance status of 0 and 1, they were randomized according to the stage 1B versus 2 or 3A, and according to EGFR mutation, exon 19 deletion and L858R to osimertinib or placebo. And the drug was continued till the progression, recurrence of disease. And the primary endpoint was DFS in the stage 2 and 3A patients.
And secondary endpoints were DFS in overall population, DFS at 2, 3, 4, and 5 years, overall survival, safety, and quality of life. Next slide. So these are the results of primary analysis of Dura trial after 1 year of completion of therapy, and we can see that there was significant improvement in primary endpoint DFS. In this curve is for stage 2 and 3A population. That was the primary endpoint. Here we can see that there was significant improvement in DFS with hazard ratio of 0.17. And this is overall population. Here also we can see that the curves were separated from the beginning, and there was significant improvement in DFS. So in next few slides, we will discuss about updated analysis of this Dura trial after maturity of 50% and the patients who have received the drug for at least 3 years. We will focus on the results DFS according to the stage, according to the CNS disease, and we will focus on the toxicity of the drug. Next slide, please. So these are the baseline characteristics, and we can see that both the arms were well balanced in terms of age, smoking history, race, performance status, and stage of disease. Majority of patients were of adenocarcinoma histology. EGFR exon 19 deletion was in around more than 50% cases, and it was 45% cases were of L858R mutation. More than 50% patients have received adjuvant chemotherapy in this setting. Next slide. So now we look at the results. These are the updated DFS in stage 2 and 3A stage. That was the primary endpoint. And here we can see that there was significant improvement in the DFS with osimertinib, with hazard ratio of 0.23, means there was 77% reduction in the risk of recurrence of disease with osimertinib, and the PFS was 65 versus 21 months. Next slide. These are the results in overall population, means here we have included stage 1B disease also. And here we can see that there was significant improvement in DFS, 65 versus 28 months with hazard ratio of 0.27. Next slide. This is the subgroup analysis. We can see that all the patients were benefited with the osimertinib. We should focus on the stage. We can see that patients who were having stage 3A disease, they were benefited more in comparison of stage 1B and 2. Patients who have exon 19 deletion, there was slightly more benefit in these patients. And patients who have received adjuvant therapy, the results were more favorable with osimertinib in these patients. Next slide. Next slide, please. So these are the results according to stage. Here we can see that patients, as that stage advances, the benefit was more with osimertinib. Here we can see with stage 3, maximum benefit was with stage 3A. The hazard ratio with for stage 1B was 0.41. It was 0.34 for stage 2, and for 3A it was 0.20. And here we can see the curves are also reflecting the same things. For stage 1B, the benefit was less, and it was maximum with stage 3A. Next. These were results according to AJCC 7, and the authors again restaged the disease according to AJCC 8th edition. And the results were consistent in all the stages with when the disease was staged at AJCC 8th. Next. So this is the pattern of recurrence of disease. Here we can see that maximum recurrence occurred in lung, lymph node, CNS, and bones. The most common first site of recurrence was it was around 12% in patients in placebo arm, and it was 26% in patients who received, in 26% in patient in placebo arm, and it was 12% in patients who received osimertinib. Here we can see that the CNS recurrence in lymph node, all were benefited with osimertinib, and rate of recurrence was very low in these patients. Next. So if we focus on CNS disease, the CNS DFS in patients with stage 2 and 3A, there was significant improvement in DFS, and it was not reached in both the arms, but there was significant improvement in hazard ratio of 0.24. Next. And the estimated probability of observing CNS recurrence in absence of non-CNS recurrence or death at 36 months was 2% in osimertinib arm, and it was 13% in placebo arm. Next. Next slide. Now we come to the toxicity. Here we can see that the toxicity was consistent with the previous analysis, and there was no toxicity was higher in osimertinib arm, but there was no adverse effect that leads to death in both the arms. Next. Diarrhea and skin-related adverse effects were more with osimertinib, and interstitial lung disease was observed in 11 patients who received osimertinib, and QTc prolongation was reported in 30 patients in the osimertinib arm versus 8 patients in placebo arm. But the drug was well tolerated. Next slide. So with this analysis, after 3 years, when patient have completed 3 years of osimertinib, we can say that there was 77% reduction in the risk of death, risk of recurrence or death with adjuvant osimertinib versus placebo in stage 2 and 3A population. That was the primary endpoint. Median DFS was 65 months versus 21 months. And there was also 73% reduction in risk of disease recurrence or death in all patients, including stage 1B. There was improvement in DFS was seen regardless of whether patient received prior adjuvant chemotherapy or not. And the benefit was consistent with the AJCC 7th and 8th staging, and osimertinib demonstrated clinically meaningful improvement in CNS disease also. So we can say that after 3 years, the safety profile was consistent with established safety profile of osimertinib, and there was no safety concern reported in this study after 3 years. So we can conclude that these updated data reinforce adjuvant osimertinib as the standard of care for patients with EGFR mutated stage 1 and 3A NSCLC after complete tumor resection with or without adjuvant chemotherapy. Thank you. Thank you for patient listening.
Thank you, Dr. Ajay. So our next speaker is Dr. Deepak Shukla. He'll be talking on time to target met with vision in NSCLC. Dr. Deepak?
Yeah, thank you. Thank you for the opportunity to speak on this topic. I'll share my slide. Just a moment. are my slides visible now?
Yes, sir.
I'll be speaking on the topic time to target MET with vision in non-small cell lung cancer. The NCCN and all the recent guidelines recommend to do a broad molecular profiling in advanced non-small cell lung cancer. We know the reason behind. We have number of new mutations that are coming up, and one of these mutations is MET exon 14 skipping mutation. This mutation now has a number of treatment options available. Previously, crizotinib was the only available agent. Now we have capmatinib and tepotinib. In addition, these mutations also give a chance to the patients when we do this testing to be enrolled in appropriate clinical trials whenever available. So the MET exon 14 alterations, they are found in close to 3 to 4% of newly diagnosed advanced non-small cell lung cancers. Predominantly, they are seen in adenocarcinoma histology. There is some suggestion that the sarcomatoid variant has a more frequency of this mutation, and it is the rare patients with the squamous cell CA around 2%, and even large cell CA may have this mutation. The oncogenesis with MET exon 14 skipping mutations occurs because this mutation leads to a protein that is lacking the juxtamembrane domain, which is responsible for MET ubiquitization and degradation. So in the absence of this domain, there is increase in the MET receptors on the cell surface as they are not degraded, and thus leading to increased MET signaling, which drives oncogenesis, leading to proliferation, survival, and metastasis by triggering the downstream pathway. In the VISION trial, the MET alteration was tested using the liquid biopsy, tissue biopsy. Particularly, the liquid biopsy was done using the Guardant 360 assay. The tissue biopsy was done using the Oncomine Focus assay, and particularly in Japanese patient as a trial set, they used the LC Scrum study assay. And in clinical practice, we know that NGS is possibly the best method to detect this mutation. And more importantly, RNA-based NGS is the way to detect this, this mutation. So all NGS, one must remember, is not the same. So there are various studies showing that the NGS platform using DNA will be able to detect only 20% of these mutations, while if we are not doing simultaneous RNA NGS along with it. So the goal is to do both DNA as well as RNA NGS to diagnose this patient. What this study from 2016 showed that this study enrolled patients or looked into the patients from stage 1 to 4 non-small cell lung cancer patients. And it showed that patients who were having MET exon 14 skipping mutation tend to have a worse survival across the whole spectrum of the stage, while the patients without this mutation were doing better. What has also been shown by a number of retrospective studies that patients who are having MET this exon 14 skipping mutation, if they do not receive this MET inhibitor as a part of treatment, their median survival is close to less than a year. While if you use MET inhibitor, their survival is close to 2 years. And it is good to know that now we have a number of agents available for targeting this, from crizotinib, and recently we had capmatinib, and soon in a matter of 1 to 2 weeks, we'll have another agent, tepotinib, available for the use in India on freely basis. At present, the drug was available in as a part on compassionate basis. So the tepotinib at a dose of 500 milligram once daily has a potential to improve compliance. It has a long and half-life that ensures small peak and trough variations over 24 hours, potentially reducing the toxicity at the peak and suboptimal inhibition at trough. And the VISION trial was the largest study of its kind, which across the globe included close to or screened 8,000 patients, with close to 350 patients selected. And these presentations have been done in a number of conferences with a number of international publications. So the VISION was a phase 2 multi-cohort, multi-centric trial of tepotinib in patients with stage 3B4 non-small cell lung cancer, patients with PS 0/1 with MET exon 14 skipping alteration being diagnosed on liquid or tissue biopsy in a central lab were enrolled. So initially, the trial began in the cohort A in September 2016, when the drug showed activity. Subsequently, a cohort C was enrolled, which was done to assess the confirmatory analysis in this whole population. And cohort B, I won't be discussing, that is for MET amplification. So overall, if we look into the both cohorts A and C, there were close to 275 patients. Approximately 137 patients were treatment naive and close to 148 patients were previously treated. And the primary endpoint was overall response rate, and these were the secondary endpoints. The initial data that I'll discuss now is at a data cutoff date on February 2021. And the trial was designed keeping the clinical practice in mind, because we know that often doing tissue biopsy is not feasible in all patients with lung cancer, where tissue is always an issue. So liquid biopsy was enrolled as a treatment plan. So VISION protocol had 3 analysis sets for all endpoint: tissue biopsy population, liquid biopsy population, and combined population, including both tissue and or liquid biopsy. In this trial, if we compare to other targeted subset, the targeted mutation population, in this trial, the median age was close to 72 years. Patients were elderly. The sex distribution was equally distributed between male and female. The majority, or again, the smoking status was equally distributed. And almost majority of the patients were adenocarcinoma, with around 10% patients having a squamous histology, and close to 20% patients with brain metastasis were enrolled. If we look into the data of patients who responded to the data for treatment naive patients enrolled based on the tissue biopsy, close to 86 patients, the overall response rate was 54.7%. The disease control rate was 80.2%. And it is encouraging to note that almost greater than 90% of these patients had some tumor shrinkage. The duration of this response was close to 32.7 months. The PFS was 15.3 months, and median overall survival was close to 30 months. The patients who were enrolled in this trial, who were previously treated, they also derived numerically a slightly lower benefit, with the response rate of close to 50%, disease control rate of 80%. And also in this previously treated population, also greater than 90% patients had tumor shrinkage. The duration of response was 10.1 months. The median PFS was 11.1 months. The overall survival was 22.3 months. What this data showed that this is the consistent sensitivity to tepotinib therapy regardless of the biopsy method. So whether we do a tissue biopsy or we do a liquid biopsy, whether a patient is treatment naive or previously treated, but what we can see from this table is patients with liquid biopsy were having a lower PFS, whether they were previously treated or they were treatment naive. And possible reason for this was the patients with liquid biopsy had a higher tumor load, and more patients with brain metastasis were there in the liquid biopsy cohort. And recently in ESMO 2022, one of the data regarding efficacy of tepotinib in patient previously treated, and it showed that irrespective of the prior treatment, so whether a patient has received chemotherapy, IO plus chemotherapy, or IO, the duration of response, PFS and OS was seen irrespective of the previous treatment received. If we look into the Asian subset, which was close to 1/3 of this study population, the patients in the Asian cohort were majority were males. Close to 42% were having a smoking history, and nearly 2/3 were previously treated. And again, the benefit, if we look into the PFS and OS data as the numbers what we have seen previously, it is comparable to what was seen in the overall population. Tepotinib was also in this data set, there were 51 patients who are having a brain metastasis, and the overall response rate was 53%. The disease control rate was 76.5%. The median duration of response was close to 9 months. The median PFS was close to 8.5 months. And overall, 87% intracranial disease control rate was seen. And as already discussed, that the Vision cohort C was the confirmatory analysis for this data set. And this was the update at 9 months follow-up was presented at WCLC. The cohort C showed that this data shows that the overall response rate, median PFS, median overall survival in cohort C, the confirmatory data set was equivalent to the cohort A, and the median PFS, OS were comparable. If we look into the patients who were treatment naive, enrolled based on tissue biopsy, if we look into the overall response rate in cohort C, again, the response rate was close to 62%. The median duration of response in these patients who were treatment naive and enrolled based on tissue biopsy was not reached, while in cohort A, it was 46.4 months. If we look overall, including cohort A and C, the median duration of response was close to 46 months, while the median PFS was approximately 15 months, and median overall survival was close to 2 years. And also similar benefit in cohort C was seen in patients who were previously treated and enrolled based on tissue biopsy. So median PFS was close to a year, and median overall survival ranged from 19 to 20 months. In the cohort C also, the duration, the overall response rate was equivalent to what was seen in cohort A. The overall efficacy in cohort C and A was robust and durable across therapy lines. So whether it was first line based on tissue biopsy or liquid biopsy, or in second line, the median PFS in the cohort C was slightly better, and the median overall survival was similar. The tepotinib in general, if we look into the tolerability, the discontinuation rate, if we look into the both cohorts A and C, it was close, the permanent discontinuation was close to 15%. The most common side effect was any grade was peripheral edema, and this was also the most common grade 3 side effect. The grade 3 side effect subsequently more common was hypoalbuminemia and ALT increase, while other side effect like blood creatinine increase, which is possibly a class side effect, which is also seen with capmatinib, was greater than grade 3, was less than 1%. So the simple once daily regime of tepotinib improves the patient compliance, as already mentioned, less than 15% discontinuation, adverse profile which can be managed by simple dose modification, low treatment related peripheral edema, and the other side effects as mentioned previously. And this safety profile has been tested in approximately 300 patients in this Vision trial. And in metastatic setting, one of the goals of our treatment is quality of life. And as mentioned in the Vision trial, the median age was close to 72 months. So even in these patients, if we look, the quality of life was maintained. If we look into the comparison between tepotinib and capmatinib, we know we cannot compare the cross-trial data because patient population may be different. But what is encouraging to note that both the drugs are active with a good more than 50% patients in the first line treatment being having a response, and the median of duration of response with tepotinib in the treatment naive cohort was 32.7 months, Again, disease control rate, median PFS is almost comparable, and grade 3 or greater side effect was slightly means lower in the tepotinib as compared to capmatinib. So tepotinib with simple once daily dosing is one of the drugs which we can use in these 3 to 4% patients which are having otherwise poorer prognosis, which will improve, which will lead to the efficacy endpoints as discussed. And also we have now data based on the vision that we can very confidently give it either based on tissue or liquid biopsy, knowing that the safety is good and also the quality of life is maintained. Thank you.
There is a question for Dr. Shukla, I think, regarding the liquid biopsy. Someone has asked. So will you go in the question and answer box and would like to answer it?
Sir, will you use this drug for MET amplification? So
that is my question, but there is another question in question and answer box also. Not in the chat box.
Okay. Is it liquid biopsy is gold standard? Liquid biopsy is diagnostic test or monitoring test for those patients who has blocks not having any tumor content. So liquid biopsy for MET exon 14 skipping mutation can be used as a diagnostic test. Recently, we have data for EGFR based on the APPL data. We can monitor and change treatment in EGFR based on the liquid biopsy. But for MET, I don't think we have data that we can change treatment based on the liquid biopsy. It is more of a diagnostic tool at present for patients who are having no tissue, means we can use this simultaneously along with tissue biopsy.
And would you like to use it, Dr. Shukla, as on today for the amplification also, or it's only for MET exon 14?
So, sir, again, means the approval as such, if we look, is for MET exon 14 skipping mutation. But if we look into the data for the cohort B, the data is almost as good, I think, means the PFS is similar, though slightly lower, but I'll be using it even in MET amplification.
Thank you.
Thank you, sir.
Good evening. Who is going to start the next session?
So my request would be if you can start the session, sir, because we already have Samra online. So.
Okay. Okay. So good evening once again to everyone and thanks. So now we have a different sort of the presentation, and we have with us Ms. Samara Mahindra, the founder and director from the Integrative Healthcare and Lifestyle Private Limited. She will be talking in a different way regarding the growing evidence of integrative oncology for better quality of life, improved treatment, adherence, and survival. And you all will agree with me that these are the few of the aspects of the cancer care, which due to our busy practice being sometimes we become purely the pharmacological doctor or the chemotherapist, that the other aspects of the oncology, the need of the patient regarding the nutrition, the caregiving, we sometimes miss in the busy practice, and sometimes they are being overlooked, or we don't have the time to monitor those aspects, even if they are being provided by someone. So how they can be more integrative in the modern style where almost every information is available through the net or through the various social media. So what's new in this aspect? For that, we have with us Samara Mahindra. We will be welcoming ma'am, and over to you for your presentation. Thank you.
Thank you and good evening, Dr. Somani. Thank you for the opportunity. I'm just going to switch on my video and share my screen. Please let me know once you're able to see the presentation. Please let me know if you can see my screen.
Yes, ma'am.
Great. So firstly,
slide is visible. Yeah. Yes.
Okay, great. So firstly, I wanted to thank you for inviting me here. As you had mentioned, Dr. Somani, this is very different to what the esteemed oncologists have spoken about. But my expertise lies in integrative oncology. We have built a company, one of the first in India, that provides integrative oncology evidence-based solutions for better quality of life, improved treatment adherence, and survival. And today that's predominantly what I will speak about. Quick overview of the presentation. We will go over the problem and solutions that we all face in oncology today, a little bit about integrative oncology and the evidence that supports integrative oncology on different cancer types, a little bit about Cairo, the impact that we have made, the outcomes, the technology we use, and very, very important point which you had mentioned, which is enhanced patient adherence that we are all trying to achieve on in India and on a global scale, the value proposition, partnerships, and vision of what we are trying to do. To start off with, I think we all can agree that unfortunately, when it comes to cancer, there is a substantial diminished quality of life on all levels. It affects us from a psychosocial, psychological, nutritional, physical, and many levels when we hear a cancer diagnosis and actually go through treatment. Compliance is a big problem. Compliance to medication, adherence is a big problem. And there are multiple reasons why this happens. We usually believe it's predominantly finance related, but during my years in integrative oncology, working with the best around the world and also today in India, we realize that there are multiple other facets that improve adherence, and that's something that we will talk about. Of course, we all face excessive treatment costs, and as you had mentioned, the patient to oncologist ratio in India today is a big discrepancy, and all oncologists are doing their best and they are overburdened because there are so many and the rising cancer rates today that there is a massive difference in the ratio of patients to doctors. So the solution that we propose is that integrative oncology is a well-established way of treating patients around the world. It uses personalized clinical nutrition, physical rehabilitation, and psychological interventions and protocols to improve quality of life, to improve medication compliance and adherence, as well as decrease overall cost of treatment. When it comes to our solution and what we do, we have inbuilt risk stratification assessments, which gives us an understanding of the level of risk of non-adherence of every patient who starts a cancer treatment protocol, and gives us an understanding of which patients require deeper, stronger, more comprehensive interventions to support them through their treatment regimen so they can stick to the treatment regimen and compliances. And of course, because we as integrative oncology solutions manage the ancillary, the supportive elements of oncology treatment, while the medical treatment is the main focus. Of course, doctors can attend to many more patients because, as you will agree with me today, that most doctors are bombarded with questions like, what do we eat? How do we manage our physical symptoms? How do we manage our quality of life? The acceptance of the disease when they have just been diagnosed is a big factor and has a major psychological implication on the patient and the family as well. So we take care of all of that from a very, very evidence standpoint, from a comprehensive standpoint, so doctors can focus on the main treatment. Integrative oncology, as I mentioned, and I'm sure all of you doctors know, is the integration of clinical and non-clinical modalities of care. And you'll be surprised to know that about 80% of cancer patients use some form of integrative therapies globally, and over 90% of breast cancer patients use the same. The problem in India today is that there aren't that many evidence-backed scientific solutions of integrative oncology programs. So most patients are going and opting for alternative forms of treatment online that can be detrimental to their their diagnosis and their survival as well. So that's the problem we're trying to solve, is to support the patient from a clinical standpoint, from an evidence-based standpoint, to actually enhance quality of life and work with the oncologist to improve outcomes. Integrative oncology is a very globally established protocol. We have Memorial Sloan Kettering, where I had my first encounter to the Integrative Oncology unit there. From MD Anderson, we have a Global Society of Integrative Oncology platform. And if we were to look at any major hospital or healthcare institute in oncology around the world, in any developed country, they all have integrative oncology units. A little bit of evidence of integrative oncology on multiple myeloma. Of course, the impact of integrative therapies on various different indications have been proven. Here are some. For multiple myeloma, we have noticed that lifestyle interventions improved the overall physical functioning, fatigue, quality of life, psychological distress, and long-term health outcomes of multiple myeloma cancer patients. The same with the oncology. In fact, we in India see a large group of breast cancer patients, and the largest response to integrative therapies and integrative modalities has been with breast cancer patients. We have seen a substantial decrease in anxiety, stress, mood disorders, and of course, improved conditions of nausea and vomiting and overall quality of life. The next study that I want to talk about is another one from ASCO, and this one is pretty profound because it was the use of integrative therapy and treatment for 3 months and its impact on lung cancer patients. What is noticed in this study is that there was a significant increase in probability of survival, as well as an improvement in overall quality of lives for lung cancer patients just with 3 months of an integrative cancer treatment approach. This was a study that just came out in JAMA this year, a very interesting study that shows how an improved progression-free survival does not equate to improved quality of life. So one is that we would always believe that, in most cancer drug trials, that if we see an improved progression-free survival, that also means that the quality of life of the patient improves. And that's not the case at all. In fact, sometimes it's quite the contrary, and that's when integrative therapies come into play to actually fulfill that gap, to make sure that the patient is supported on all elements. While they are experiencing a progression-free survival, they are also improving their quality of life parameters. A little bit about Cairo and the company that I represent. We are the first and only integrative oncology solution in India. Are the 3 facets of what we provide in the oncology spectrum, and along with all the medical doctors, is in oncology nutrition, which is personalized integrative nutrition for cancer patients, physical therapy in the form of specialized yoga therapy and physiotherapy, and third is the psychological intervention, according to me one of the most important, that is provided to the patients and the caregivers. What we do want to mention here is that while it seems simple to manage the nutrition, physical, and psychological element of a patient, the way the therapy is delivered and by whom it's delivered plays a profound impact on, again, adherence and quality of life. All the experts on our protocol are, of course, coming from a very strong clinical background, but they are trained further just in oncology and work very closely with our partnered hospitals, doctors, and healthcare institutes to manage all the different deficiencies a patient might experience, whether it's neutropenia or drop in blood counts or extreme nausea, fatigue, appetite, or whether it's lymphedema, post-surgery rehab, pain, fatigue, malnourishment, weight loss, and definitely the psychological element, which is anxiety, depression, fear of relapse, fear of death, how to go back to a new normal, and also very important factors like how do spouses interact and how to maintain relationships during a cancer diagnosis and treatment, which is many a times in a country like this shoved under the carpet, not spoken about, but has a massive impact on how patients are actually recovering. The length and breadth of care has been quite vast, just I think based on the incident ratio and also the level of diagnosis and stage of diagnosis in this country. We have seen more stage 3 and 4 cancers, but seen a very interesting equal distribution of female and male. And of course, we've worked with over 25 types of cancers. And if we were to subtype that, then that would be, even greater number than 25. This is a very simple outline of the kind of data we have achieved. We have used QLQC30 assessments. These are globally validated assessments of quality of life metrics for oncology. And what we have focused on is nutrition, physical and psychological therapy, and the impact of quality of life on cancer patients. As you and I can, agree over here, is that when patients are on very severe treatment or on serious extensive treatment, just keeping them stable is an effort. So to see an improvement in actual quality of life, and which is fatigue, digestive issues, appetite loss, cancer anxiety, pain, nausea, of 86% in a cohort of 200 patients is pretty outstanding. We have also done a small clinical trial with HCG hospitals and Dr. Vishal Rao, where we saw 100% compliance, and again, an outstanding report in quality of life metrics for these head and neck cancer patients. This study is being published in the Journal of Precision Oncology in October 12th, so next month actually. Just a quick patient journey. What we do is very much enabled by technology, but when it comes to oncology, 100% digitization does not work. We and our team, who is on the ground working with patients 24/7, we go into their homes, we are interacting with their entire family. We understand that the front facing has to be human touch. There has to be a level of compassion, empathy, and the first touch point with any patient plays an integral role in how the patient responds to the program and the treatment. When it comes to nutrition, there are frequent nutritional changes that happen with the patient. So personalized attention coupled with technology is when we can see 100% personalization. So while everything is tech enabled and we have multiple assessments that we do from the start of a patient being on our protocol and then through the journey, which is shared with the medical team, all the therapies are led by actual therapists who keep providing a personal touch to the patient and keep modifying the recommendations of the therapy based on the pain points of the patient. The technology interface is one where we have built a very strong platform. It is a simple front-facing app, nothing too complicated, where patients have very easy access to all our therapists 24/7 and can interact with them 24/7. We also have a health tracker for patients. And one thing that we have included, which has been very wonderful for all our doctors, is a personal doctor dashboard where by 24/7 they or their team can log in and see how their patients are doing at any point in time. When we're talking about enhanced patient adherence, there is substantial amount of data that supports this. And here are some studies that shows how integrative oncology per se, included in a treatment protocol, actually improves medication compliance and adherence. This is another study that talks about integrative medicine and how it should be included as a part of patient care in a clinical routine for maximum quality of care and safety with complementary therapies. The way we focus on initiating adherence to therapy are three major factors. We need to understand that when we look at medication adherence, it doesn't merely rely on financial support. While that plays a huge factor, education and empowerment plays a very important role. Most patients are misinformed. Most patients don't have enough information. And unfortunately, what we have found through all our data is that a lot of the patients have a negative connotation to treatment. So as soon as a patient starts feeling better, especially if they are on long regimens of treatment, they stop taking the drug. And that's because of just misinformation. So education plays a very imperative role to make them understand how important the treatment is and how important it is to complete the duration of treatment. Accessibility and engagement and implementation plays an imperative role. We are with the patient 24/7. While we have very comprehensive facilities in India today, I'm sure all the oncologists over here understand the importance of this and provide these ancillary therapies to their patients. We also know that when the patient leaves the vicinity of the hospital or your doctor's chamber, we lose touch. And implementation becomes a problem. That's why the patient comes back after 21 days, neutropenic, malnourished, has excessive amounts of fatigue or pain, because there is no hand-holding that we can actually provide to the patient when they go back home. And that plays a very, very important role in keeping the patient on the treatment and also improving quality of life. So that's essentially what we do, is to provide the extension of care into the patient's home beyond what is offered in the clinical setting. And then, of course, the psychosocial and financial support. Every enrollment with a patient or any encounter we have with our doctor's patient is a human interaction where we then allow the patient to understand how important the treatment is and how important measuring and actually sticking to the integrative therapies to improve quality of life plays for them. And then, of course, we have an entire onboarding process. Medication adherence is one of the factors we focus on. This is just a snapshot of how we look at adherence. We use an Mmas screening test. This is a
Abra, sorry to interrupt. Great presentations. Couple of minutes to close, please.
Yes, absolutely. Thank you. So the Mmas score that we use is actually a screening test that gives us an understanding of the risk stratification of the patient in terms of adherence to treatment. This is being used globally. What we noticed is in some cohorts of patients, it was just the tendency to forget to take the treatment, or when they travel, they weren't able to take the or forget to take the treatment. And that's when we realized that just sending notification medication reminders improved adherence. So when we do these screening tests, we get an understanding of where the lag is, where the dip is, and then actually provide therapies that manage quality of life, and whether it's as simple as just sending medication reminders that have actually improved adherence. And coming to the last slide, of course, what we do is to improve the overall quality of life, to improve significant survival of patients. And when I say we, I'm talking from the Integrative Oncology platform. And we need to really, really make this a part of cancer treatment protocols in India as it's being done globally, because this supports the outcome of the patient. Today, we're moving in a more patient-centric world. Patient-reported outcomes are becoming a part of clinical trials, and working with the medical fraternity to provide evidence-backed solutions for patients so they don't opt for alternative modalities of treatment that can be detrimental for them is important. And that brings me to the rest, to the end of the presentation. We have multiple partnerships. And as I had already spoke about the fact that the vision is to make this a part of mainstream oncology treatment in India today. Thank you so much. And I would be happy to take any questions that you might have.
Is there any question from anyone? We are happy to have some interaction with ma'am. It's a sort of the rare opportunity that we have this kind of the presentation in the mainstream webinars or the medical conferences. Just to make a comment that the biggest challenge to integrate the integrative oncology is the non-reimbursement. And with the more and more support system from the government side, I think the mindset of the patient is like this, that everything should be free. So we need to design something from the reimbursement stakeholders, from the insurance companies or the TPA or the government agency, that there should be at least certain subsegment of the patients who definitely need the integrative aspects of patient's treatment holistic approach, the nutrition, the financial management, and so many things. Because we always believe that the cancer is not a disease which individual is suffering, it's the family disease. So everyone is suffering because of the long, lengthy treatment, the costly treatment, side effects, and so many things. So with this, we would like to thank Madam Samara Mahindra once again. If there is no question, thank you, ma'am. And very soon we are optimistic, we are hopeful that we will be having the interaction with you in the Jaipur to have the understanding in a better way that how the carer is providing the services or taking care of our patient or going to take care of our patient in the near future.
Absolutely. Thank you, Dr. Somani.
Thanks, ma'am. And with this, I would like to hand over for the next proceeding to our consultant medical oncologist from HCG Jaipur, my colleague, Dr. Jitendra Pahlajani, to start the next important session that is about the hematology.
Thank you, sir. Thank you, sir. Good evening, everyone. So this is the section regarding hematological malignancy. So I would like to invite the chairperson, Dr. Pankaj Tatia, who is a consultant meta-oncologist at Acharya Tulsi Regional Cancer Center, Bikaner, and Dr. Vishnu Sharma, consultant Department of Hematology, SMS Hospital, Jaipur. Over to you, sir.
I think Dr. Tantia will not be able to join this. He gave me the message. So we request Dr. Vishnu Sharma and as well as to Dr. Jitendra also to bear all the responsibilities on their shoulder. Dr. Vishnu, to you.
Yes, sir. Thank you, sir, for the opportunity, and thank you, Dr. Jitendra, for kind introduction. So next session will be on the first talk will be on SHINE study, which is a study of ibrutinib in combination with bendamustine rituximab, followed by rituximab maintenance as first-line treatment for older patients with mantle cell lymphoma. And the talk will be delivered by Dr. Manoj Mahajan. Dr. Manoj is Director Oncology Services, Senior Consultant Medical Oncology at Pacific Medical College Hospital, Udaipur. Over to you, Dr. Manoj.
Can you run my slide? Am I audible?
Yeah, you are audible.
Can I even run my slides?
The slides are not visible.
No, I'm just asking to run the slides. Just a second, I'll try. Is it visible now?
Yeah, it's visible now.
Yes, sir.
Yeah. So the study is about the ibrutinib plus bendamustine and rituximab in previously untreated mantle cell lymphoma. First of all, I would like to thank organizers as well as the study like Wang et al. So this study addresses an important subset of patients who are elderly patients, where the role of ibrutinib in addition to standard conventional treatment BR has been evaluated. So the context forming is like BR has improved PFS, bendamustine and rituximab has improved PFS versus conventional other conventional treatment including RCHOP, RCOP of nearly more than 13 months with better safety profile for the treatment patients with the mantle cell lymphoma. So it has been now a standard of care in most of the patients where we don't see the aggressive treatment and where especially in the elderly subgroup, the toxicity profile has to be minimized. So there are a few studies which emphasize the maintenance role of maintenance rituximab after BR, which improved PFS as well as OS, which was similar to the benefit as seen in the rituximab maintenance after RCHOP. So the new concept was ibrutinib. Ibrutinib is the first-in-class oral BTK inhibitor, which has transformed and has shown the durable activity in relapsed refractory mantle cell lymphoma patients. So the next question was how to improve upon upon all these things. So the phase 1b study demonstrated addition of ibrutinib to PR or standard arm was safe and efficacious, but it was a phase 1b study. So safety profile and efficacy was assessed, and CR rate was nearly 76% in patients either untreated or
Dr.
relapsed.
Manoj, sir, sorry to interrupt, but your slides are not moving. Can you make it full screen and then because you're still on the slide number 1.
Yeah, I'm still on slide number 1.
Achha, okay, but if you can make it full screen, that should be fine, sir.
Yes. Is this okay? Can you see the next slide?
No, sir, it's not moving, sir.
Same page?
Yes, sir.
So I should stop sharing and again reshare.
Yes, yes. Just close the slide, then reopen your slides again, sir.
Visible now?
Yeah, it's visible.
So,
so
this study is
it's not full screen. Still, it's
नीचे जो आपके दिख रहे हैं नीचे उसको full screen कीजिए ना sir, because what you are saying is
full screen. I've done the full screen. I can see it's in full screen mode.
No, not full screen. Still.
ठीक है sir, you can go to the next slide, no problem. Please go ahead.
So this study is can you see the second slide?
Yeah, it's visible.
Yeah. So this study is mainly in the elderly patients, which are like previously untreated mantle cell lymphoma, more than 65 years, stage 2 to 4 disease, and no planned stem cell transplant for this subgroup. And stratified factor was simplified MIP score, low, intermediate versus high. So number of patients enrolled were 523, randomized in 1:1 fashion, received standard VR induction followed by rituximab and maintenance every 2 months for 12 cycles in patients who have received CR or PR, along with the ibrutinib versus the placebo arm. So ibrutinib was addition to PR and maintenance was continued. Primary endpoint was PFS in the intention to treat population. So the patient demographic and disease characteristic at baselines were quite well matched. So I would like to highlight like mainly stage 3, stage 4 patients. Stage 4 patients were nearly 98% patients. Stage 3 nearly 7%. Stage 2 barely few. Most of the 1/3 patients were high risk. Nearly half of patients were intermediate risk, and nearly 16% patients were low risk. Bone marrow was involved in nearly 75% or 3/4 of the patients. Nearly 80% patient has non-blasted or pleomorphic variant. External disease was present in nearly 89-90% of patients.
Dr. Manoj, slides still not moving. You are still on slide number 2.
Is it visible now?
No, it's not visible. Your name is visible only.
Now I guess it's visible.
Yeah, it's visible.
Yeah, it's moving. Slide is moving.
Still not moving. Slide number 4.
Patient disease and characteristic.
Yes.
Slides are not moving. Actually, it's moving on my end. Not able. Can anyone run the slide from their end?
Yes, sir. Just give me 2 minutes.
Apologies for technical glitch.
Sir, can you please?
Yeah, next. Next slide. Next. Next. Yeah, next. Yes, this slide. So baseline characteristic in the population demographics were quite well matched. As we can see, high risk, nearly 90% patients were high risk. Bone marrow involvement was seen in nearly 3/4 of patients. Blastoid variety was nearly 7 to 8% of patients. Extranodal disease was nearly 85 to 90% patient. Nearly 1/3 patient has a bulky disease, and nearly 10% of patient has P53 mutated. Next slide. So what was the primary endpoint of PFS? Was median PFS at the end of nearly 7 years, so 80.6 months versus 52.9 months with HR of 0.75 and p-value of 0.00. So there is significant improvement in median PFS by 2.3 years, 6.7 versus 4.4 years. And there is 25% reduction in risk of progressive disease or death. So the PFS as a primary endpoint was made statistically. Next slide. If we see the forest plot, most of the patient subgroups benefited in this group except high-risk patient. As we might expect, we need an additional high-risk aggressive therapy in such subgroup. But most of other low-risk, intermediate risk, and low intermediate risk patients, even the bulky disease and non-bulky disease benefited equally. Next slide. So if we see the what was the PFS in the high risk subgroups, we can see blastoid and P53 mutation. PR had a numerically improved median PFS, though it was not statistically significant. So if we conclude in terms of median PFS in high risk patients, including P53 mutation, it was more than 2 years in combination with the ibrutinib plus BR versus less than 1 year. In VR alone. Next. So if we see the response rates, again, response rates, CR is slightly higher. Overall response rates are more or less matching, numerically higher, but CR rate was higher in ibrutinib arm. Next slide. Time to next treatment. If we see relapses happen more commonly in VR arm versus ibrutinib arm. So subsequent therapy at second line, ibrutinib has only 99% or nearly 20% patients required, while in placebo arm, nearly 40% patients or patients required second line therapy. Next. So what are the common treatment emergent adverse events? More than 20%. As expected, ibrutinib, in addition to BR, had its class effect and more side effects in terms of neutropenia, diarrhea. Then rash was quite common. Thrombocytopenia, anemia, pneumonia, infections were quite common in ibrutinib arm. Next slide. So if we see what are the chances, there is a high risk of chances of bleeding. Major bleeding was 5.8% versus 4.2, but any type of bleeding is nearly double that of what it was in the placebo arm. Cardiac side effects, especially atrial fibrillation, nearly 14% patient in ibrutinib arm. Hypertension, more or less similar, and arthralgia, 17% and versus 16.9%. So during the entire study, second primary malignancies, including skin cancer, occurred in nearly 20% patient in the ibrutinib arm, while 19% in the placebo arm. MDS and AML were also reported in 2 to 3 patients, respectively. Next slide. So the OS, if we can see, OS is more or less same. So and there was no statistical difference in the overall survival. And if we look at the death data, nearly 58 patients had death in the ibrutinib arm versus placebo nearly 70%. Next slide. As this period also included COVID, few of deaths were attributed to COVID. So to conclude, the median PFS in the ibrutinib arm was 6.7 years. It is giving nearly 2.3 years of PFS advantage. The adverse events were consistent and expected as profile of ibrutinib and BR. So it is definitely a new benchmark for the patients who are older subset and even in like low risk and intermediate risk group. Except high risk group, probably we need some better solution as we have seen in the subset analysis. Thank you.
Thank you, Dr. Mahajan, for quick and nice overview of science study. The next speaker is Dr. Pawan Kumar Singh. Dr. Pawan is senior consultant and head Department of Hemato-Oncology and Bone Marrow Transplant Physician at Artemis Hospital, Gurgaon. He will be speaking on the 3 years follow-up of Captivate study, that is fixed duration ibrutinib plus venetoclax for first line treatment of CLL, SLL. That is 3 years follow-up. Over to you, Dr. Pawan. Dr. Pawan, are you there?
It was unmuted. Okay. Yeah. Can someone present the slide, because I can't see the this presentation mode icon on my. So I'll stop sharing. Can someone share from the management side?
Sure, sir. Sure, sir.
Yeah, please. Yeah. Thank you. Can it? Yeah, put some presentation. Okay. So thank you once again. So I'll be discussing about this study. So we all know that nowadays oral treatment has almost replaced, and it is now approved as a frontline treatment as well, and in the relapse refractory setting also. So if we see ibrutinib plus venetoclax is an all oral drug combination which can be used in the treatment of CLL. So this is very important study recently published, and so fixed duration ibrutinib plus venetoclax for first line treatment of CLL, SLL, a 3-year follow-up study, and it is phase 2 study. Next slide, please. So this is the study design. It is basically 3-year follow-up data from the fixed duration cohort of Captivate study, which is presented, and it's a multi-center phase 2 study evaluating first-line treatment with 3 cycles of ibrutinib followed by 12 cycles of combined ibrutinib plus venetoclax. So these are the almost 160 patients, newly diagnosed patients less than 70 years with good performance score. So initially ibrutinib was given as a lead-in phase with 420 milligram once daily, that is the standard dose. So 3 cycles was given, 28-day cycle, and then after that 12 cycles of ibru-ven combination. Venetoclax was used given as a schedule of ramp-up schedule with up to a maximum dose of 400 milligram once daily. And then after that, the treatment was ended, and then the patient was put on follow-up. And during follow-up, if the patient had any kind of progression of disease, so retreatment options were included, including again continuous or fixed duration improvement combination. So again, it was restarted in terms of when there was progression of disease. So median time of study was 38 months. 92% of patients completed planned 12 cycles of combined treatment, and median treatment duration was almost 14 months. Range was from 6 months to almost 0.54 months to almost 25 months, and which is equivalent to almost 15-28 day cycle. The median of 25 months follow-up or after completion of. So these are the standard characteristics. Almost all kinds of CLL, including deletion, high-risk cases of deletion 17p with TP53 mutation, complex karyotype, and if the median ALC absolute lymphocyte count was 70%. So even high-risk, all group of patients were included in this study. Next slide. So this was with an additional year of off-treatment follow-up. Since the primary analysis, rates of CR and undetectable MRD remain high. So the CR rate in this study of all treated patients increased from 55% at primary analysis to 57% with an additional year of follow-up treatment. And 79% of patients had a best response of undetectable MRD in peripheral blood or bone marrow. And of the patient who achieved undetected MRD in peripheral blood at 3 months post-treatment, 78% of these patients maintained this undetectable MRD level through 12 months of post-treatment follow-up. Next slide. And with an additional year of off-treatment, we can see that the follow-up since the primary analysis improvement, it continued to provide high rates of PFS and overall survival. So this was treatment free period, and we can see that though the TP53 and deletion 17p and unmutated IGHV CLL patient, they had less PFS as compared to, but long-term follow-up, if you see all treated patients, it was equivalent. But though, as it is expected, these group of high-risk CLL patients had less. And estimated 36-month PFS was 88%. And in fact, in TP53 mutated cases or unmutated IGHV, at 36 months of follow-up, the response rate, the PFS was almost similar. And the estimated 36-month overall survival was 98%, which was similar in TP53 mutated and unmutated. So even in high-risk patients of CLL, the response was maintained in terms of PFS and overall survival. Next slide. And there was another point, is because in the inclusion criteria in the study design, we mentioned that the retreatment was also allowed with single-agent ibrutinib, and single-agent ibrutinib, it shows the promising response rate, onset, and resolution of recurrently occurring adverse. So retreatment, 12 patients who progressed after fixed duration treatment have been retreated with single-agent ibrutinib with duration of retreatment ranging from 6 to 32 months. And out of these, 11 patients are evaluable for response, and these 9 patients achieving PR, 1 patient achieving PR with lymph node persistence, and 1 patient achieving stable disease. And most frequently occurring adverse event was more than 30% of patients were usually grade 1, 2, and are occurred in 4 months of treatment initiation. And usually these are resolved. These are the common adverse: nausea, vomiting, neutropenia, and arthralgias. Next slide. So finally, to conclude, fixed duration improvement continues to demonstrate deep and durable responses in clinically meaningful PFS rate of almost 90% at 3 years, and PFS more than 80% even in those patients with high-risk disease like TP53 or unmutated IGHV. And with additional year of follow-up, no additional overall survival events occurred. The safety profile is manageable and unchanged from that previously reported. Most frequent adverse events were very low grade, and 4 months of treatment is standard, and high rates of improvement or resolution. Early data suggests that patients who progressed even after fixed duration treatment, they can be successfully managed when they were retreated with single agent ibrutinib. And ibrutinib venetoclax, it represents an efficacious all oral once daily chemotherapy free fixed duration regimen for previously untreated patient with CLL or SLL. So I will stop here. Thank you.
I request Dr. Vishnu Sharma sir for his expert comments.
Dr. Vishnu sir, you need to unmute yourself, please.
Thank you, Dr. Pawan, for excellent talk. So basically, the CLL treatment has evolved over a period of time, and now time has come where CLL patients will be treated with only oral agents, because ibrutinib, acalabrutinib, venetoclax, all these drugs are effective in TP53 mutated patients, IGHV unmutated patients, and the combination of ibrutinib plus venetoclax will be standard of care because of its beauty of fixed duration treatment. And for the mantle cell lymphoma, I think the combination of this ibrutinib plus plus bendamustine rituximab will be standard of care in patients who are not eligible for transplant, even in patients with the presence of deletion 17p or TP53 mutation. So thank you for sparing your time and excellent talk. Over to you, Dr. Jitendra.
Thank you so much, sir. Thank you, everyone. Thank you to the speaker. I would just like to add one point that in mental, if at all patient is not affordable for a transplant or not fit for transplant, I do believe that Arasi-based therapy will give us a deeper response. So probably that also one thing which should be kept in mind. And then I will held the mic to the organizer. Thank you, everyone. Good day.
Sorry to interrupt. There is a question in the question answer box. So will you be kind enough to make some comments or answer that? Not in the chat box, in the question answer box. Regarding the CLL, so anybody can take that question from the previous two speakers.
Which marker is good prognosis in CLL and which is poor prognosis? This is for Dr. Pawan. I think he has left. So basically, the presence of mutation of TP53 or presence of deletion 17p and unmutated IGHV, these are the high risk factors for CLL patients, and preferably these patients should be treated with novel agents like ibrutinib, acalabrutinib, or combination of ibrutinib plus venetoclax.
Dr. Vishnu, like the markers previously which we used to read like JEPS 70 or others, do they have any relevance as on today?
Sir, I don't think there is any relevance of doing these tests because everything is based on molecular mutations. So presence or absence of deletion 17p, presence or absence of mutation of IGHV status, these are the two important things. And CLL IPI also includes beta-2 microglobulin, the RAI and this RAI staging system also.
Thank you.
So can we invite the next speaker, please, Dr. Somani, sir?
Yeah, please go ahead. Please go ahead. We are waiting.
So is
yeah. Is my screen visible? Yes, ma'am. Just make it full screen, ma'am. Yeah, perfectly fine. Thank you. Thank you. Okay, so yeah. Shall I go ahead with the presentation?
Yes, Dr.
ma'am,
Charu. Yeah.
Okay, so very good afternoon to everybody. My special thanks to Dr. Somani for giving MedGenome an opportunity to be part of this extensive oncological update webinar. So I have been allotted a very interesting topic, which is NGS in hematological malignancies. Is it parallel to solid tumors? So a pretty interesting question. Definitely, I mean, I will just take you through the insights of NGS in hematological malignancies per se, and we can have a discussion a little bit around how much it is getting parallel to the NGS, which is nowadays used in solid tumors as well. The agenda will be what are the genomic technologies being used in hematological malignancies. I will be focusing on AML being the most heterogeneous disease and having the most number of mutations as compared to any other hematological malignancies, and then certain case studies to illustrate how NGS is relatively parallel to solid tumors as well in terms of its implication. So genetic testing overall in clinical oncology is profound to have a great impact on hereditary cancer risk assessment. Definitely not only for hematological malignancies per se, but also for solid tumors, hereditary risk assessment has become one of the major part of doing the screenings and getting the early detection and preventive oncology and being part of preventive oncology, be it solid tumors, breast, ovarian, pancreatic, or be it AMLs or other such diseases. I definitely find a lot of relevance of using genetic testing to estimate the risk of individuals for different cancers. And definitely when we talk about differential diagnosis, so in case of differential diagnosis, there are a lot of mutations and biomarkers that are being defined these days to categorize the tumors, to differentiate between two different overlapping tumor types, be it your in terms of solid tumors or also your hematological tumors, where your genetic aberrations or molecular aberrations define a particular tumor and pave the way for giving a particular kind of treatment. Next thing is prognosis. So prognosis, if you look at prognosis, has in case of prognostification for AMLs, for ALLs, and for all different types of leukemias, the prognostification is definitely done through additional biomarkers that are being mentioned in the guidelines, and the use of these markers is becoming more and more important to take decisions in terms of doing the hematopoietic stem cell transplants or not, and finding out how the patient is going to be. And also, if you look at solid tumors, genes like TP53 or even BRCA1, BRCA2 genes, every other genes, KRAS, all of them have a prognostic role to play. They inform the clinician about the aggressiveness of the disease and how aggressive the treatment should be in terms of when we go on selecting the therapies and deciding on the treatment. Next is therapy selection. So if we look at the therapy selection, this is one of the prime areas where you can find the implication of next-gen sequencing per se. Next-generation sequencing gives you a benefit of detecting more than one biomarker at a single point of time using a very little amount of DNA or RNA, and you can have a landscape of mutations out of which you can select which mutation is targetable and can give you a better outcome both in hematological and solid malignancies. One of the most important upcoming area is therapy monitoring and surveillance. So the very commonly and the hot topic we come across these days is MRD, which is minimal residual disease monitoring. So be it your solid tumors or hematological malignancies, MRD estimation has become the need of the hour, and there are a lot of new technologies that that are coming up in terms of ctDNA or cfDNA monitoring by using the variant allele frequency in the floating DNA, cell-free DNA that is floating in the plasma of the patient. You can monitor the VAF VAF or variant allele frequency, that is the percentage of that mutation that is present, that can indicate upon the therapy and also on the chances of relapse. Secondly, if you look at the picture in the hematological malignancies, earlier there were only implications of doing the MRD by flow cytometry, which is an well-established and validated method, but due to its certain limitations, molecular MRD is becoming more and more prevalent and is being explored lately very extensively also, like in terms of you can estimate it, the percentage or the presence of the most important mutations that you are targeting post-treatment, and you can find out whether there is disease left or not, because as we look at the proteins that are present on the surface of the cells that act as that are estimated in flow cytometry, we can even look at the mutations or you can say the particular mutations, though that becomes the ID of that particular cancer cell present in the bone marrow, which is causing leukemia. If it is still present, it can be detected up to the rate of 10⁻⁻⁶. So this is kind of a whole parallel correlation you can find out, illustrate in terms of solid tumors and hematological malignancies. So genetic mutations can be detected with different technologies. We have next generation sequencing to find out for point mutations, that is single point mutation change, and large deletions and duplications can be detected with MLPA and fragment analysis. However, NGS has an ability to detect those, but with certain lower specificity. When we come to translocations, that is the exchange of genetic material between two chromosomal positions, particularly, those can be detected by karyotyping, FISH, RT-PCR, and NGS per se. In case of NGS, you have an option of doing it by RNA sequencing, which relatively helps you to get even the translocation partner, and also has an advantage of finding out any cryptic fusion partner, that is, which is not routinely found partner, like something else with ABL gene instead of BCR, or something else with DRARA instead of PML. So those kind of cryptic translocations can be very well identified using next generation sequencing. So next generation sequencing, if we look at the stepwise flow of it, we have the genomic DNA or RNA. We fragment the genomic DNA or RNA which we get from any kind of sample, be it tissue, bone marrow aspirate, or peripheral blood. We fragment we get the fragments of this DNA by enzymatic method, and then we hybridize these fragments with the probes or the targeted sequences which we want to sequence for. Then we go for a washing and pull down so that we get only the DNA which we are targeting for. The captured DNA is then put into a sequencer, and when the data is received, there is mapping, alignment with the human genome sequence, and then we can call the variants using various bioinformatic tools so that we can identify the changes that takes place as compared to the normal human genome sequence. So next generation sequencing has made significant roads into clinical molecular diagnostic laboratories for routine testing of tumors. In a very short time, this technology has shown a drastic impact on scale, quality, and variety of diagnostic sequencing which we can do, because it has an ability to do high throughput and massively parallel sequencing. You can screen for variety variety of genomic changes in a multiple samples simultaneously, and this has made this particular platform as a platform of choice, so that clinical testing of solid tumors and hematological malignancies both can be done with high precision and high sensitivity. According to National Survey of Precision Medicine in Cancer Treatment, it indicated that in 75.5% of the oncologists use NGS testing to guide for treatment decisions, which reflects the growing impact and utility of NGS in oncology overall, be it solid tumors or hematological malignancy. So if we look at the targeted NGS, which is routinely used these days, it is one single test where you can look for all key biomarkers across multiple samples, be it mutations, be it translocations, all can be picked up in a single test. And you can have a very little amount of DNA and RNA, and you can get very great resolution. You can get high discovery power. You can find out new variants, novel variants, and you can find out answers to all possible roadblocks which come in the way of treating diseases like AML. So if you look at AML as per the new ELN 2022 guidelines, there are certain genetic analysis tests that have been indicated in case of AML, and first is cytogenetics, which is a gold standard, which we do by karyotyping. Next is to look for gene mutations that are required to establish a diagnosis and identify therapeutic targets such as FLT3, IDH1, IDH2, MPN1, SEPA, DDX1, 41, TP53, and other such genes. Then next important thing is to look for gene rearrangements by such as PML-RARA, in version 16, AML, ETO, KMT2A rearrangements, BCR-ABL, and other gene fusions if available. Last thing is additional genetic testing, which involves to look for other prognostic markers in AML. And we know that 95% of the AML patients either have a driving and conquering mutations, regardless of the presence of cytogenetic abnormalities.
Ma'am, sorry to interrupt. May we request you to be a little bit in time, ma'am?
Sure, ma'am. Sure, sure. So I will just now move on to the AML diagnostics in terms of various updates that are there using the NGS. So first is genetic predisposition. So there are several new updates that are included now for the germline detection of SEPA, TP53, RUNX1, GATA2, all these different variants which are being included as germline predisposition factors for AML patients. Next is to look for the AML classification. We have to categorize them on basis of genetic aberrations, where NGS and other molecular technologies play an important role. So according to ELN 2022 guidelines, AML is classified into for risk categories. A new category of favorable outcome is BZIP, in-frame mutated SEPA, and in the adverse categories they have added the mutated ASX1, BCOR, EZ2, RUNX1. So these are the two important changes which have been done in ELN 2022 guidelines. Moving on, how genetic testing helps you to detect new clones in the AML disease journey of a patient. We can do the genetic testing at different steps, and we can identify the mutations with different VAFs, that is MPN1, CKIT, ASXL1 at the time of treatment, then after the consolidation therapy, and after the hematopoietic stem cells. We may find upcoming of different new clones which can help us to establish the same thing. Now coming to MRD, in case of MRD, NGS is mentioned as an exploratory method, and it has a sensitivity of getting up to 10⁻⁴. It is difficult to, in terms of you have to run an error-free NGS, and it has to be very specific as to establish the sensitivity of finding a marker which was detected before the treatment. Otherwise, I will just show you one example where we are using the NGS MRD in AML cases. So now coming to case studies, this is first one is 31-year-old female with AML, found out with FLT3, ITD and IDH2. Post-induction, there was no clinically relevant mutation found. So the testing was done at 2 point of time using NGS itself. In a 32-year-old male, we post BMT, we found a WT1 and NUP98 NST1 fusion, which indicates a poor prognosis combined together. And definitely this is being correlated with a paper which I found out, and by Wang et al. The same kind of combination was found in these case in this particular case, and suggested to have a very poor prognosis. Next is detection of CBL syndrome in a patient who is undergoing a post-induction, post-MRD BMA for finding out whether the donors also have a CBL syndrome or not. So the patient was screened for CBL syndrome and using the buccal swab, and the possible donors were also screened, so that if the CBL syndrome is present in the donors, they will not be using the donors for the bone marrow transplant for this patient. So germline predisposition testing is also important. This case illustrates that. And next important update is the AML MRD by NGS. So TP53 gene was found in this patient at the start of the treatment at 62.2%, and after the treatment it was found to be at 0.1% per se. This is the lower allelic burden, which was done after almost from December till the 6th of July. The next testing was done. So definitely,
Ma'am, sorry to interrupt. Excellent presentation as always. Last 2 minutes to conclude, please.
Yeah, just 2 slides are left. So definitely the key takeaway is that NGS has a very important implication in diagnosis, treatment, response, relapse, and if there is secondary treatment being given. NGS can help you to identify new clones. It can help you to find out late driver mutations, and it can give you an MRD assessment as well. So that is the journey of NGS in hematological malignancy, particularly AML. And I think that it is definitely parallel to solid tumors. So that's all, and I would be happy to answer any questions. Thank you.
So in quick words, ma'am, what's your experience of second NGS at the time of relapse or for the subsequent? What's your experience?
So, sir, if you can, I have just shown a case where the NGS was done at the second relapse, at the time of relapse. So this is a post BMT patient who was relapsed and checked for what are the causes of a relapse in a post BMT patient. So we have definitely we find certain important poor prognostic mutations at the time of relapse in these cases, and it gives a great insight that if this kind of evaluation had been done earlier, before the bone marrow transplant was planned, this could have been helpful in terms of deciding the marrow transplant for the patient and expecting the prognosis.
Thank you.
Yeah. Thank you, sir.
Thank you so much, ma'am.
So, Surbi, can you invite the next speaker?
Yes, sir, sure. So I would like to invite Dr. B.A. Savita. She is a laboratory director, OncoSteam Diagnostic Private Limited, Bengaluru. Ma'am, kindly proceed.
A very good evening.
Yeah, good evening, ma'am.
Yeah, are you able to see my slide?
Yes, ma'am, just make it full screen.
Yes, I'm doing that. 1 second, just give me a second.
It's the last session, ma'am. We are a little bit late, so I will
Yes,
request you
yes,
to be a little
yes,
quick.
yes, yes. I'm just trying to figure out how to, yeah, 1 second.
Ma'am, your slides are moving. So you come to the first slide and then make it full screen.
Okay.
Yeah. Make it full screen, madam.
Okay, sir. Actually,
Ma'am, on the downside.
If not, you can start presenting, ma'am. You can
Yeah,
go to
we'll
the
do
next
that.
slide. Please start, ma'am.
Or press F5, I think.
F5, okay. Yeah, yeah, sorry for the delay, and I'll get right in. Firstly, thank you for giving OncoStem Diagnostics the opportunity to share the platform with all the august speakers here. And today I'll be talking about the benefits of Canna's breast in early breast cancer patients. I'm Dr. Savita, I'm the Laboratory Director of OncoStem Diagnostics. We will be talking about prognostication in hormone receptor positive, HER2 negative early breast cancer. And as we all know, prognostic tests help decide on the use of chemotherapy. Oncotype DX and MammaPrint have been there in this area for very long, and they were developed in US and Europe. They are widely adopted. They're part of many guidelines, NCCN, ESMO, AJCC prognostic staging. These have led to the reduction in chemotherapy use in the Western countries, resulting in improved quality of life. So typically, patients get diagnosed with hormone receptor positive, HER2 negative early breast cancer. They undergo surgery, and a prognostic test is done after that. And the patient, if categorized as low risk for recurrence, is can be treated without chemotherapy. And if the patient is diagnosed as a high risk of recurrence, then the patient benefits with chemotherapy. And as we all know, there are differences in the presentation of breast cancer patients in the Indian Asian setup versus the Western setup. So in Indian setup, what we see is younger age of onset and almost a decade earlier presentation, with 48 being the median age. And what we see is symptomatic detection, primarily stage 2 diseases, higher tumor burden, and many more node positive cases. Whereas in the Western patients, these patients are postmenopausal, older at onset with 60 plus, median age. These are screen-driven detections, largely stage 1 cases, smaller tumors, and primarily node negative tumors. Hence, we require a prognostic test which is useful in our patients. So to meet this need, Canna's breast was developed on Asian patients by Dr. Manjari Bakre at OncoStem Diagnostics, which was started in 2011. So this actually is a proteomic classifier which uses the gold standard immunohistochemistry platform. There are 5 biomarkers which are critical signaling molecules in the pathway of tumor recurrence. This, along with the morphometric parameters like tumor size, grade, and node status, these are incorporated into the proprietary machine learning statistical algorithm, and subsequently a Canna's breast risk score is generated. This could be anything from 0 to 100, with 15.5 being the cutoff. So if it is 15.5 or less, the patient is categorized as low risk, and these are the patients who can safely forego chemotherapy. This is around 70% of the patients. And if it is 15.6 or above, these are the high risk patients, and these are the patients who benefit from chemotherapy. Canna's has been validated on 4,000 plus patients from India, US, and Europe. We have a very high accuracy of, with 95% negative predictive value, which is comparable to that of the Western test. And the Canna's biomarker patents are granted across many countries. We also have several peer-reviewed scientific publications. And it is important here for me to emphasize the fact that, the Canna's biomarkers are not ER/PR, HER2/neu, or Ki-67. These are the markers which play important role in events in cancer progression. So what is it that makes the cancer in the breast to undergo and form a metastasis? The sequence of events is epithelial mesenchymal transition takes place. There is loss of cell to cell adhesion. There is invasion. subsequently extravasation, and the cell undergoes again mesenchymal epithelial transition, and in the process there is acquisition of drug or chemotherapy resistance, and subsequently a distant metastasis formed, whether it is in the brain, lung, or bone marrow. And many markers were analyzed, and subsequently these 5 markers, CD44, NN pancreatic, and drug transporter proteins ABCC4 and ABCC11 were identified to play important roles in events in cancer progression. And this slide showcases the development paper which is available in Biomarker Insights, and any test needs to be analytically validated, and the analytical validation shows the robust behavior of the test, and excellent repeatability and reproducibility. That also has been done and it's published. We also have validated the testing on Ventana benchmark and also in TMA mode. We have also done a lot of clinical validation, and all these papers are available. I will be showing the links to that later in the study. And also coming to all the data, which is how CAN-assist breast actually works. So when we look at this graph here, what we see here is the entire cohort of patients who received chemoendocrine therapy. What we see here is 69% of the patients were categorized as CAN-assist breast low risk, and these patients have a better DMFS of 94% as against the 31% of the patients who were categorized as high risk who have a poorer DMFS of 82%. So there is always this question, okay, is chemotherapy confounding these effects? So we look at the patients who receive only endocrine therapy. So in this also what we see is CAN-assist breast is able to identify the 19% of patients as high risk and who have a poorer DMFS of 84% as against the low risk patients who enjoy a better DMFS of 95%, and the NPV of CAN-assist breast stratification has been more than 94%. And coming to CAN-assist breast risk stratification, whether it is in less than or equal to 50 years or patients above 50 years. And when we look at this graph here, which is the patients who are younger patients, less than 50 years of age, here also what we see is a 70-30 proportion of patients getting segregated as low risk and high risk. And again, we can see a statistically significant segregation with better DMFS of 93 in the low risk patient against the 79 in the high risk patients. In above 50 also, we see the similar trend. The segregation is again statistically significant. Proportions are fairly similar, and we see that DMFS of the low risk patients is better at 99.4 as against the high risk DMFS of 84.4. So CAN-assist shows that it is useful in patients both above and below 50 years of age, and the NPV remains more than 93%. Also, CAN-assist stratification is independent of node status. As we saw in Indian patients, we do see a lot more node positive patients. So we looked at the patients who are node negative, and this is a sizable cohort of 1700 plus patients. In this, CAN-assist segregates almost 82% of the patients as low risk with a better DMFS of 95%, and the high risk patients, which is a proportion of 18% of patients, these have a poorer DMFS of 88%. And again, when we see the node positive population, even in this, there is a statistically significant, segregation. There is a good number of low risk patients, which is around 51, which is almost every other patient who's categorized as low risk. And, there are 49%, which is at high risk, who have a much poorer DMFS of 80%. Thus, it is useful in both node negative and node positive patients, and NPV remains more than 92%. Coming to the clinically low risk patients. Now, these are the patients who are either T1 node negative or T1, T2 node negative. In both these categories, these are the patients who were treated with endocrine therapy alone. In both these categories, CAN-assist is able to identify the 7 or 9% of the patients in T1, T2 who are at high risk and who will benefit from chemotherapy. Thus, it helps us identify even the prognostically high risk patients in this typically clinically low risk patients. Coming to how is there a chemotherapy benefit for high risk patients only? We looked at data in a different way. So we looked at all the patients who are segregated as CAN-assist breast low risk, and what we saw was what treatment did they get? This blue line here is the patients who received chemoendocrine therapy, and this red line here is the patients who received endocrine therapy. As we can see, these lines are overlapping, and the DMFS is also 96%. So what it means is, when Can-Assist Breast segregates the patient as low risk, whether they receive chemotherapy or endocrine therapy, the patients behave in a similar manner. Whereas when we see the Can-Assist Breast high-risk patients, the patients who received endocrine therapy have a poorer DMFS of 79%, as against the patients who did receive the chemotherapy, and they have a DMFS of 93%. So this 14% difference here is the chemotherapy benefit, and it shows that only high-risk patients benefit from the use of chemotherapy. And we have also done extensive global validation of Can-Assist Breast, and more than 21 studies have been conducted with over 4,000 patients from all over, many institutes in India and many centers in Europe and US. And what it has gone to show is that Can-Assist works with equal accuracy across various geographies and ethnicities. This is one of the recent publications of Can-Assist Breast validation data from Europe. It goes on to show that even in European patients, Can-Assist Breast is a robust tool. With this, I would just I'll just show you briefly the comparison between how the Indian subcohort and the Caucasian subcohort do. When we look at the subset of patients who received chemoendocrine therapy, whether they are Indian or they're Caucasian, we see somewhat similar proportions. There's 72-73% of the patients getting categorized as low risk, and their DMFS is also similar, 94-95%, and high risk patients are around 27-28, and they have a poorer DMFS of 83-85%. And when the patients who receive endocrine therapy alone is seen, whether they're Indian patients or they're Caucasian patients, we see around 80-20 proportion, and DMFS differences again, significant. Thus, it shows that independent of the racial or ethnic differences, CAP works very accurately. And now we'll look at the comparison of Can-Assist with Ki-67, NPI, and PREDICT. Ki-67 remains a popular marker used in breast cancer patients, and in the just from chemotherapy, and the intermediate category of 6-29%, these are the patients who should undergo prognostic testing. With this in mind, in our cohort, what we saw is 50% of the patients got categorized as low risk and 14% as high risk, remaining, which is a sizable population of 36, as the intermediate risk. And the same patients, when they underwent Can-Assist Breast testing, what we see is a 75-25 proportion of patients getting categorized as low and high risk, and low risk patients enjoy a better DMFS of 95%, vis-a-vis high risk DMFS of 82%. So we also looked at the Can-Assist Breast, how it segregates patients in the intermediate risk category, and in that also what we saw is a 74% of the patients getting categorized as Can-Assist low risk, and they have a equivalent DMFS of 95%, and the high risk patients, which is 26% of these patients, they have a DMFS of 84%. Thus, Can-Assist stratifies 25% more higher number of patients as low risk than Ki-67, and it proves itself to be a better tool. Coming very briefly to the...
Ma'am, you need to conclude your discussion. Maybe another 1 minute, please.
Okay, I'll just take 2 minutes. I have 2-3 more slides only. Yeah. So very quickly going into the comparison of Can-Assist with online tool Nottingham Prognostic Index, Can-Assist identifies a greater number of patients as low risk as compared to the NPI. Also, NPI categorizes 55% of the patients as moderate prognostic group. So this is a problematic category which will not help the clinician to make a diagnosis. And Can-Assist identifies high-risk patients even in the clinically low risk, that is T1 N0 tumors as compared to NPI. Also, what we see is even in N1 G2 tumors, Canasis identifies greater number of patients as low risk. And this is a very busy site. I'll just skip it. Actually, it just goes on to say that, Canasis works very well in the, clinically high risk patients, T2, N1, and, grade 3 tumors also. Canasis shows a significant hazard ratio. These are the hazard ratios, whereas, whether it's NPI or PREDICT, they do not show, significant hazard ratios. Even when we look at the, how the NPI and PREDICT, they perform in India and Europe, what we see is Canasis proportions remain somewhat comparable, whereas, NPI categorizes very few patients as, good prognostic group, and PREDICT is also like almost half of the patients. Thus, it works as a, far better tool. ODX to Canasis breast also head-to-head comparison was done, and what we have seen is a 83% concordance in the oncotype DX and Canasis breast in the low risk category. I'm not showing you to the data, but MammaPrint also we have seen a 85% concordance in the low risk category. Coming to the TEAM trial, this was a 10-year recurrence prediction by Canasis breast. TEAM is a tamoxifen exemestane adjuvant multinational trial, and basically in this what we did was, these patients had outcomes available for 10 to 12 years. This was 480 patient tumor blocks from Leiden University Medical Center, Netherlands. These is a primarily postmenopausal node positive cohort treated with hormone therapy alone. The gist of this slide is Canasis breast works very well at 10 years also. We are able to segregate the patients in a very effective manner in the 10 years also. Canasis has been prescribed for many doctors in India. Now we are reaching out to Turkey, UAE, Sri Lanka, Bangladesh. 71% of the patients have been categorized as low risk, leading to, saving, by avoiding chemotherapy. We have reimbursement facility also. Many oncologists have given, favorable testimonials and spoken in favor of how Canasis is helping the patients. Even oncologists in Turkey have spoken that they found the tool to be very helpful. And oncologists have spoken about Canasis breast in national conferences and webinars. Finally, why choose Canasis breast? It has a multi-country validation. Importantly, it is validated in the Asian younger patients. It is an which is priced 4 to 5 times lower than that competitors. It has a score AI ML based technology, and we are a very quality driven lab. We have ISO 13485 accreditation, CAP accreditation, NABL accreditation. We have one of the fastest turnaround times in this category of 7 to 8 days. To summarize, what I would say that it's a robust and cost-effective ISC-based prognostic test, and it works independent of cohort-specific differences, age, and node status. Chemotherapy benefit is observed only in high-risk patients, and over 83% concordance is observed in CAB low-risk and Oncotype and MammaPrint low-risk categories. And Canasis is a much more accurate tool than Ki67, Luminal, AB, and IHC4. It prevents both under and over treatment of patients. And the data so far has shown 71% of the patients have been saved from chemotherapy in a prospective manner. And now it has shown that there is excellent segregation even in 10 years, and also we have excellent outcomes in post 5 years of follow-up of the patients. Thus, it remains a very good tool in an Indian setup. These are all our publications, and Dr. Manjari and OncoStem have been given many multiple awards. And with this, I'd like to thank you, and I'm very happy to take any questions.
Thanks, Dr. Savita, for the excellent presentation. Definitely is I will say that Make in India, and you are moving that propaganda or the vision of our country, our Prime Minister. And it's I can call it like the Oncotype DX of India, or for
Thank
our
you.
patient, as you have rightly said it. And if no question to Dr. Savita, we would like to conclude this session. With the due permission of the chairpersons, can we conclude today's session? So I would also like to announce the prize-winning question from Dr. Mukandar Sheikh. He regarding the prognostic value of the various markers in the CLL. So I think he deserves this award. And the best time attending, we will be announcing it later on. We have to do the analysis of the data. So with this, I am thankful to all of you once again, all faculties, participants, speakers, delegates, all the sponsors, that they came wholeheartedly to support this important webinar based on the recent updates and the breakthroughs from the WCLC and from as well as from the ESMO 2022 and recent updates also. And once again, thanks to all my scientific committee members. Once again, to enumerate them, Dr. Vijay Patil, Dr. Vamsi Krishna, Dr. T.P. Sahu, Dr. Bharat Vashwani, Vikas Talreja, and in the last but not the least, the team Horizon, under the able guidance of Mr. Tarun Mathur, that he's doing a wonderful job to make the presentation, arranging the things, bringing everyone on the platform, and doing my job easier and simpler. With this, I would like to conclude this today's session. Once again, thank to all of you. Happy Navratri, happy festive season, happy Diwali in the coming days. Once again, thanks. Good night. We can conclude today's session.
So thank
Mr.
you
Tarun,
so
you
very
want to
much.
say anything? Yes.
Thank you so very much, Dr. Somani sir. On behalf of the organizing team, my colleagues Surbi, Pooja, it's extremely great 2 days of excellent deliberations by everyone. So thank you so much. Shubh Ratri, Shab Bakhair. Stay safe, stay blessed, and have a very nice weekend.
Thank
Good
you
night
so
from
much,
all
sir.
of us.
Good night, sir.